Good morning, everyone, and welcome to the Commission for Behavioral Health meeting. My name is Mayra Alvarez, and I'm the chair of the commission. We will now take roll and establish a quorum. Please note that under the Bagley-Keene Open Meetings Act, any commissioners who are participating remotely must keep their camera on at all times and will be asked during roll call to disclose if they have any other adults over the age of 18 in the room with them during the meeting, and of the nature of their relationships with these individuals. Sandra, will you please take the roll?
Thank you. I do request that our commissioners joining us remotely unmute their lines, and everyone, and just as a reminder, everyone in the room, please also use your mic, because if you do not use your microphone, the folks on virtual cannot hear you. So I'm ready to establish quorum. Commissioner Bear.
Aye. Sorry, aye.
Is there anybody in the room over the age of 18 with you?
No.
Thank you. Commissioner Burnick.
Here, and there's no one in the room with me.
Thank you. Commissioner Bontrager.
Here, and there's many people over the age of 18 here.
Commissioner Brown. Commissioner Bunch.
Present.
Commissioner Callan.
Here.
Commissioner Carnevale.
Here.
Commissioner Chambers. Commissioner Contreras.
Here.
Commissioner Designee Swartz. Commissioner Cross.
Here.
Commissioner Fairweather.
Here.
Commissioner Fernandez.
Here, and there's no one under the age of 8, or no one over the age of 18 in the room. Or under.
You. Commissioner Gordon.
Here.
Designee Pulmano. Commissioner Larson. Commissioner Madrigal-Weiss.
Here.
Commissioner Mitchell. Commissioner Robinson. Commissioner Southard. Commissioner Sy.
Here.
Commissioner Wilkies.
Present.
And is there anybody? Oh, you're in the room, sorry. Commissioner Roulette.
Here.
Chair Alvarez.
Here.
We have quorum.
Thank you, Sandra. We're going to move on to agenda item 2, announcements and updates. And before we begin our usual announcement and updates, I'd like to take a moment to welcome our newest commissioners. And some of them are joining us today. And so let's welcome them. Amy Fairweather, filling the seat for a Veterans Organization representative. Welcome, Amy. Brandon Fernandez, representing individuals who have experienced substance use disorders. Welcome, Brandon. J. Raya Thomas Beckett, representing individuals who have experienced mental health disorders. And Javon Wilkes, filling the seat for a representative of a children and youth organization. We are so excited to have each of you on board and look forward to the meaningful work and the expertise that you will bring to this commission. Thank you for being with us, especially after such short notice from your announcement. It's really great that you're here with us and that we can begin to have your representation and expertise as part of our conversations. I will invite the public to chime in during the general public comment period to speak to these announcements, but I also want to begin by giving our newest commissioners an opportunity to introduce themselves. So let's begin with Commissioner Fairweather, please.
There we go. Thank you. I'm honored to be appointed. I am the veteran advocate representative. I've worked in veteran advocacy for 20 years at Swords to Plowshares, where we provide mental health care, substance treatment, housing, both transitional, permanent, supportive housing, legal services for benefits, largely having to do with mental health. Or a combination of issues, and other supports for veterans. And I'm just really thrilled to be here and look forward to working with you.
Thank you, Amy. Commissioner Fernandez.
Good morning. My name is Brandon Fernandez. Similar to Commissioner Fairweather, I'm very grateful to be here and participate in the commission. I think this is an incredibly important task ahead of us, and so I'm happy to serve. I am the CEO of Cry Help, a not-for-profit community-based organization based in Los Angeles that primarily treats Medi-Cal eligible adults diagnosed with a substance use disorder, the majority of whom also have co-occurring health conditions. I'm also a person in long-term recovery for over 12 years now. I'm a Los Angeles native, and I grew up abroad most of my life in Brazil and in India. So I'm happy to be here today.
Welcome, Commissioner Fernandez. And Commissioner Thomas Beckett is not with us at this moment, but may join us virtually later. And so I will hand it over to Commissioner Wilkes, please.
Thank you. Wow. Get to have a seat at the table. So blessed to be here. Really thankful for the opportunity. Looking forward to working with everyone. Born and raised in Los Angeles, now residing in Sacramento. Been leading the California Coalition for Youth over the last 8 years, but have been with the organization for about 2 decades, and just really amazed at where we are in California, and just looking forward to supporting the work that is going to support and make sure that our children, youth, and families and communities thrive. So thank you so much for the opportunity to speak.
Thank you and welcome. So we're excited again to have you all join us and be part of our conversation today and into the future. Our second announcement is that we're going to move on to our caring moment to help us center ourselves on the purpose of our work and the people we serve. Again, this practice is meant to ground us, with huge thanks to Commissioner Robinson, who brought this idea forward. But over the years, at least since I've been on the commission, there's been different iterations of this commitment, again, to ground us in our purpose and why we're here. This opportunity allows commissioners to share stories or moments that may be impacting others in ways that we might not always see. And we welcome ideas from our broader community as well. So please don't hesitate to reach out to commission staff if you have ideas for what that caring moment should look like for us in the future. I'm excited to have Commissioner Cross share some comments. So please, Commissioner Cross, go ahead.
Hi, good morning, everybody. My name is Commissioner Mackenzie Cross, and I will be discussing my caring moment with you all. On Wednesday, April 9th, I was honored to attend the We Live 2025 conference. It was hosted by our LGBTQ plus partners, the Mental Health America of California. And I'd like to give them a warm thank you for the invitation and for bringing us all together for such an important and a powerful event. It was truly amazing to be there to celebrate the resilience, the strength, and the community of the LGBTQ plus individuals and allies who helped make that space so special. The conference was not only a day filled with learning, hope, and connection, but also a vivid reminder as to why our work is so imperative. From the performance by Helen Heels, who was amazing, it was truly beautiful. I think that everyone should have to, experience a drag show because it was pretty cool. I really enjoyed it. But from the performance by Helen Hills to the powerful speech made by Senator Scott Wiener, this event gave us the opportunity to reflect on the tangible impact we're seeing right here and right now. Because of the dedication and hard work of our commission staff, our local community programs, and the vital funding we're investing into these communities. It's moments like this that reaffirm how truly powerful collaboration can be. As I listened to the panelists speak about both the barriers and successes they faced in their work, I was reminded of how far behavioral health has come and how much more we need to do. The challenges shared were not new to many of us. There's barriers to behavioral health services, lack of access, transportation, high cost of treatment, and painful realities of discrimination. However, the solutions, the ideas being discussed, such as expanding training, creating safe spaces, and investing in peer support, are exactly the innovative strategies we need to ensure our communities are thriving, healthy, and inclusive. I am so grateful to be a part of this conversation, and as we continue to work together with legislative and community partners, we can ensure that policies we support reflect the actual needs of the people we serve. Thank you all again for the opportunity to share my experience, and I look forward to the conversations and connections we will continue to have today. And as a youth, I will be out here doing this advocating, and I want to make sure that everyone is aware of that. I will have multiple caring moments here, whether they're shared or not. I will individually share them with people if they are interested, but definitely go to some advocacy visits or, participate in these events. So thank you.
Thank you, Commissioner Cross. Thank you for representing the commission at the event and for uplifting the importance of making space for these communities, for serving as an ally and showing up, particularly in these very challenging times for our most marginalized. So thank you very much. Our next announcement is about growing our team at the commission, and I'm going to hand it over to Sandra to introduce our new attorney, Krisangi Knickerbocker. Sandra, please go ahead.
Hi, thank you so much. I am so excited to introduce Krisangi Knickerbocker to the commission. She's up here, and I'll give her the floor to say a few words to you, but I wanted to share with you that she comes to the commission with an extensive experience at both the Department of Social Services and Healthcare Services, and she has been years in the legislative world. So she comes with tons of experience. I'm very excited to expand my team now to 2 so that we can handle all of the items, and I know she's going to be an asset to the team. Krisangi, any words that you want to share? Krisangi, Mike.
All right. I'm just looking forward to working with all of you, and it's nice to meet everyone. Thank you.
Woman of many words. Thank you, Krisangi. Spoken like a true lawyer. Okay. Thank you, Sandra. Krisangi, welcome to the commission. We all look forward to working with you. As you can see on the agenda, the commission will be moving into closed session during the lunch break. In the past 2 weeks, the Executive Director Screening Committee has continued to meet to discuss Executive Director candidates. Again, huge thanks to the members of that committee for taking time out of your calendars. I know it's a very busy time, and we appreciate your commitment and leadership. Today, the full commission will get an opportunity to consider any recommendations that the committee has. A report out will be done upon returning from the closed session of any actions taken during that meeting. Our last announcement is related to our agenda, and apologies in advance, but appreciation for understanding given the changes in quorum and the rules of Bagley-Keene. We did have to move some items around on the agenda, so I'm going to share them now to ensure that folks that are listening and paying attention to specific items to give public comment are aware of the changes. Again, thanks for your patience as we do our best to accommodate commissioner availability. The discussion around the committee appointments will begin at 10:30. The peer respite concept paper discussion at 10:50. Closed session will begin at 11:30 with a report out scheduled for 1:30. Our legislative priorities ambitious discussion will begin at 1:35. The update on recent allocations at 2:05. The Innovation Partnership Fund update at 2:20, and we will plan to adjourn at 3 p.m. That concludes our announcements this morning. Again, I want to welcome you all, our commissioners, our public, our team, to today's meeting. I will now move on to agenda item 3, which is general public comment, and this is specifically reserved for comments on items that are not on the agenda. I also want to thank our interpreter, our ASL interpreter, for being with us. As I see you moving furiously on the screen, I will take note and try my best to speak a little slower. Amariani, please lead us into public comment.
Thank you, Chair. If you'd like live meeting transcription or closed captioning, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. If there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. For members of public in the room, if you have not already, please use one of the green public comment cards located at the front to indicate you would like to make comment on this item and any other agenda items. Cards can be given to staff located at the front table. Members of the public can also email us public comment to be shared at a future meeting at publiccomment@bhsoac.ca.gov. Once the public comment procedure or period for the agenda item starts, we will close the public comment queue, so please make requests to comment at that time. You may request to make public comment by submitting a card, clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. When it is your turn to comment, I will call you to the podium or unmute your line and announce your name or the last 3 digits of your phone number. For virtual comments, I will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. We truly appreciate your understanding with this process. We currently do not have any in-room comments. We have 5 virtual comments, beginning with Jerry. Your line is open.
Great. Hi, everybody. Welcome to all the new and continuing commissioners, including Chair Alvarez. My name is Jerry Hall. I'm a certified peer support specialist and longtime advocate, having served on my BHAB and several committees and advisory boards for the past decade. I also blog at bhabrehab.com. My concern is a systemic issue that has been a longstanding problem in my county of San Diego, as well as from what I understand statewide. At the heart of the issue is the requirement that county mental health boards are required to review and approve the procedures used to ensure citizen and professional involvement at all stages of the planning process. The planning process is known as the Community Program Plan, the Community Program Planning, or CPP, and that's actually a plan which is distinct from the actual BHS operational plan, which we're now calling the Integrated Plan. Many counties are not developing this approved CPP plan. In fiscal years 21 and 22, counties spent about $9 million, or about 8% of the available $121 million on CPP activities. A complete CPP plan done before the integrated plan is created that would be reviewed and approved would include BHS stakeholder engagement objectives and goals, challenges and opportunities, and the strategies and tactics to achieve those goals. The point is that the CPP is not a brief pre-annual planning exercise over snacks. It's an ongoing engagement with stakeholders throughout the year. One remedy for this is for the DHCS to require counties to submit their MHB reviewed and approved CPP plans and budgets. To advocates and stakeholders, there's a legislated funded tool sitting on every county behavioral health advisory board shelf. Please insist on your BHAB reviewing and approving your CPP plan before the planning season is finished, or typically we just see a series of forums and not a concerted effort to keep people informed and engaged throughout the year on all the different facets of the planning process. So I share this and other resources at bhabrehab.com and invite stakeholders to become informed about the value and importance of the CPP process. It's what unifies us all. Thank you very much.
Thank you. Our next public comment is the phone number ending in 837. Your line is open. Okay, we'll come back.
Hi, this is Mark Clements, and I'm in Los Angeles. I took a look at the key newsletter from the National Mental Health Consumer Self-Help Clearinghouse. They had some major concerns with what the governor, with what the president is doing with, they're looking, because he's looking at closing up SAMHSA and moving it to a different type of agency. I think it's going to be called the Behavioral Health. I don't know what it's going to be called, but it's going to be called to the behavior. It's going to be changing, and a lot of people from the staff are being closed, being fired. So you might want to take a look into what's going on with that. It's so, and it's the key. It's called the Key Newsletter from the Pennsylvania. No, not Pennsylvania. From Mental Health Consumer Self-Help Clearinghouse in Pennsylvania. They have a newsletter called The Key, and and that newsletter is sounding out warnings with regards to behavioral health, and because of what the president is doing. Thank you, and his staff. So I would appreciate if you guys take a look into what's going on with that and do what you can to protest that taking place. Thank you.
Thank you.
Thank you, Mark. If you wouldn't mind also emailing that request to ensure that we capture your comment correctly, we'd really appreciate that. Thank you.
Okay.
Thank you. Our next comment is Steve. Your line is open.
Thank you. My name is, can you hear me okay? Just to double check. Yes. Okay, good. My name is Steve McNally. I'm a community member. I have a son with schizophrenia, and all his relationships are restored with his family, and I'm very excited about that. A lot goes to accepting and appreciating people for who they are, not trying to force like what is, what could have, should have been. Honorable Chair and Vice Chair and members, I want to first thank you for letting us as community members participate in the executive job search. I found that to be very interesting a couple of months ago. I also am glad to see that Vice Chair attended the California Behavioral Planning Council. And I hope that the ties between this commission, the council, and the local boards tightens up if we want to get the community engaged and also bring private investment to the table. So there's a couple things here. One is Department of Healthcare Services, the stakeholder groups. I'm not sure how close you all manage that or review it. Some of you are part of it, but my experience has been that it's great seeing it after the fact, but in between, as a community member, it's like watching from a distance with not a lot of discussion. And to be honest, I just sort of stopped going. And so what I would ask is this commission, I know you can't answer back and forth, but is this commission going to weigh in on any of the modules that are being set up for the BHSA? Because the devil's in the details for the proposition, and having passed by 30,000, I would suspect if you were to ask the community boards in your counties that have statutory duties of 5604.2, the only thing they approve is citizen engagement. And one of the things that we're not involved in significantly is citizen engagement, is that you look and see what's happening there and seeing if you should weigh in. The second thing is the Behavioral Planning Council has a transparency page for all members, which I'm going to propose for my own board, even though I'm, as always, speaking as an individual. That shows all your relationships. So if you're a member of an association, you have a designation as a board member of a advocacy group. It'd be good for everyone to know. And then the last topic is involuntary transport in the state is not happening because of the hands-off approach.
Thank you.
And
your time is up.
I'm going to finish real quick. And I think this is going to be a significant risk It's transferring from the sheriffs to the counties or law enforcement to the counties. And then when people don't get transported that should be put on holds, we're going to have an issue. And I think you all need to be aware of it if you're not. So thank you very much for letting me always comment, and have a terrific day.
Thank you, Steve. Our next public comment is Rarule. I'm sorry if I mispronounced. Your line is open.
Yes, thank you. All right. Good morning, commissioners. Can you all hear me?
We can.
All right, excellent. My name is Dr. Israrullah Mohammed. I'm a clinical psychologist, systems equity advocate, and the author of the Bureau Care to Custody Cemetery Pipeline, a framework now part of the Commission's public record. Having been developed over a decade of clinical practice, systems analysis, and public service, this model identifies how fragmented oversight, procedural inequity, and institutional neglect displaces children, individuals, and families from care systems into crisis, into cycles of containment, homelessness, criminalization, and irreversible loss. I speak today with deep concern about structural conditions that have persisted for nearly 2 decades under the Mental Health Services Act, conditions reflected in the $4 billion juvenile justice settlement reported on April 4th. That historic case is not just a legal reckoning, it is a systems failure warning and a call to action. The Mental Health Services Act funding cannot ethically sustain bureaucracy while failing to deliver trauma-informed, culturally responsive pathways for families in crisis. Prevention must be more than a principle. It must be practice. Practice that is rooted in lived experience, operational integrity, and public accountability. The Bureau Care to Custody Cemetery Pipeline is a prevention framework, diagnostic in its clarity, and prescriptive in its solutions. The tools are ready. What remains is not technical capacity, but the courage to lead with equity and the will to act on what communities have long named. A QR code linking to the public summary has been shared with stakeholders. I remain available for consultation grounded in ethics, equity, and systems impact. Thank you.
Thank you for your comment. Our next comment is from Will. Your line is open.
Hi, my name is Will Tage. I'm the Program Director of Substance Treatment with D.D. Hirsch Mental Health Services based in LA County. In addition to mental health and suicide prevention services, we're also a provider of substance use services, including education, screening, and outpatient residential treatment. In the past several years, per CDC data, children in California ages 12 to 18 have died more frequently from drug overdoses compared to the rate for children nationwide. Amidst instability and other past sources of support, it's critical that California steadfastly continue to actualize its commitment to funding efforts to provide substance use prevention and harm reduction services for its most vulnerable populations. To fail to do so would not only directly and immediately put the lives of young Californians at risk, it would also exacerbate California's existing housing crisis, with the NIH having identified substance use as one of the leading causes of homelessness in many cities. Organizations across the state, including D.D. Hirsch, have the ability to deliver proven interventions to prevent destructive substance use before it starts, and empower people who use drugs in taking meaningful steps to keep themselves and their communities safer. But we and others are only able to do this work as the state prioritizes investments in California's future through allocating funding to the life-saving projects of these substance use services provider organizations now. Hence, we hope to see more inclusion of substance use-related topics in future discussions of this commission. Thank you.
Thank you. Our next comment is from Kevin, and Kevin will need extended time to make public comment. Please go ahead.
Yes, thank you for the extended time. I appreciate that. Um, I'm gonna have the interpreter's gonna interpret for me. Okay, good morning, commissioners. Good morning to the chair and the vice chair. I want to just say thank you for giving me the opportunity to come to this meeting and listening to the other comments. They're right, and our social service system is really fragmented, and all of the burden is on law enforcement and civil servants who are not law enforcement. And I am a PhD student currently in public health at Loma Linda University. And I specialize in lifestyle medicine. And I have a solution to propose to, I do have a solution, and because I am a citizen who wants to be engaged in the Behavioral Health Commission. And I do propose that lifestyle medicine as a solution to that fragmented system that's breaking down. And so what we need for social services, for mental health needs and healthcare and all of that is put under the umbrella of lifestyle medicine. Like the community is included and supported and strengthened. And I propose the board and the commission to let me come present about lifestyle medicine that would be a success that's been successful here in Loma Linda. It's been very successful because it's for that blue zone principle where people have strong support, sense of community, and it's been it's a Seventh-day Adventist philosophy. So what I propose to the state of California is to consider finding a way to investigate and find a way to develop and have a participation plan where we can integrate lifestyle medicine under that and encourage medical and other services to use the billing system to provide support in therapy and preventive care and substance abuse prevention, as well as coping skills that go under lifestyle medication. So I just would like the commission to think about that and come up with different ideas that lifestyle medication that we're developing right now. And I just, as a citizen, I want to be engaged so that you guys can consider how we can work together in innovative ways for the future. So thank you so much for your consideration, and you're considering me as a citizen. And I'm not only deaf, but I have multiple disabilities, including mental health issues, and I'm also neurodivergent. So for that need of lifestyle medication as an umbrella as a whole to our current situation. So, and I know it worked for me. And lifestyle medicine is not medication. That's not what it is. Lifestyle medicine is specialized medicine. So thank you for your consideration. And that's it.
Thank you, Kevin, for your comment. Our next public comment is going to be from Richard. Your line is open.
Good morning, everyone. This is Richard Gallo from Santa Cruz County. I'm a consumer and a California Medi-Cal peer support specialist. I have two items of concerns for the commission to consider. The first one is the status of the peer workforce, because the peer workforce does not look good, while the current MHSA is being transitioned to the new BCHA commission relating to Proposition 1. We were not included in countings. Peer support, peer services was not included with Proposition 1, so we were basically excluded than being included. We are part of the mental health community. We need to sustain our workforce. Why is the state of California spending 5,000 pure specialists if the state is not going to expand the workforce? Part of the workforce needs to be included in the full service partnership. I have not had the opportunity to review the last report that came out of the commission, but it needs to be included percentage wise to encourage persons with lived experience to make a difference in the lives of our mental health community throughout the state of California. Secondly, I agreed with Jerry Hall regarding the CPP process. That's part of the reason why the MHSA partly failed statewide, because you do not have buy-ins from the Director of Behavioral Health relating to the CPP. They did not embrace that policy. They did not embrace the rules and regulations in making it integrated, especially involve consumers and families. County Santa Cruz just did the recent 3-year planning by contracting out to a consultant. And I was truly disappointed with the amount of money they spent for so little results. With consumers, it was only 20 of us that responded. Talk about poor outcome that does not give adequate pictures of the needs and the inadequate of programs and services in our community for county mental health, to see the definite picture of what the pieces are missing, what the missing puzzles needs are to help our mental health community in our communities. And that includes the deaf community. That includes families who have children and adult children with dual diagnosis of intellectual disabilities and mental health. I wrote an email to the advisory board and to the
Thank
board
you,
of
Richard. Your time is
supervisor.
up.
Okay, of my disappointment, the commission needs to take a huge responsibility in forcing the counties to do the CPP process if it's going to be part of the CC process relating to Proposition 1. Thank you.
Thank you. Our next comment is from Linda. Your line is open.
Good morning to the chair, co-chair, and members of the commissioners. My name is Linda Hart. I am a mother of a son who is schizophrenia, and I am an advocate, and I am the CEO of the African American Health Coalition. I want to speak from lived experience regarding crisis. When my son goes through his early episodes, the disconnect between, at times, I'm in the San Bernardino County, between Department of Behavioral Health and the other hospitals that have behavioral health units, and how they are disconnected. And I'll just give an example. He may go to a community hospital, get diagnosed, get a plan of action, come out, but then when he goes to his primary, there is no opportunity of what medication that was given to him when he was in the community hospital versus coming out and going to a county hospital. So oftentimes they're either over-medicated, under-medicated, and I just wish there was a better coordination on how departments could be able to talk with each other. And when we talk about continuum of care, I feel that there is a disconnect in the continuum of care, and also them having the ability to find and have a place to go in the aftercare, or even the family members receiving the plan of action. I have yet to receive any plan of action that I can use to help him. And he's been in and out of the crisis unit at least once a month because of the fact there's no really continuum of care plan that the family could use to say, these are the next steps. So I just wish that it was better coordinated for us as family members. And I could see why so many of them are out on the street, because the families just do not have the kind of resources and support that we need to be able to help our loved ones and to help save lives. Thank you for listening.
Thank you, Linda. That was our last public comment.
Thanks, Mariani. And thanks to members of the public for your comments and sharing your stories and experiences. It's a little ironic that we have a caring moment at the beginning of our meetings when oftentimes it's our public comments that remind us what those caring moments are. So just really appreciate the honesty and vulnerability that members of our public provide us and the reminder of the work that we're doing here as a commission. Thank you. Moving on to agenda item 4 is the consent calendar. This month's consent calendar includes the approval of meeting minutes from March 26th and 27th, our recent 2-day commission meeting, as well as 6 innovation plans from Monterey, Mariposa, Orange, Fresno, Marin, and Ventura counties. We're also including 2 advocacy notices of intent to award grants to 0 to 5, immigrant and refugee, and K through 12 populations. Maybe that's 3 advocacy notices. All matters listed on the consent calendar are routine and are deemed non-controversial, so they can be acted upon in one motion. So commissioners, you should have received this information a few days ago with greater detail to provide you the background, but I'm gonna go through the items and then we will open it up for discussion. So items 2 through, just kidding. First, we have the minutes from the March 26th and 27th meetings.
Mayra.
Just
Sorry to interrupt
Commissioner
you.
Chambers.
I'd like to step out of the room and recluse myself based off section 87103 of financial interests and decisions of the Political Reform Act. Oh, section 87105. I have the public identify my financial interest in the Psychiatric Advance Directives project.
And you'll be stepping out.
And I'll be stepping out of the room.
Thank you, Commissioner Chambers.
Thank you.
Just a point of clarification to our council. This is one agenda item, so if she's stepping out for the whole thing. Okay, just making sure. Okay, let me read through. Items 2 through 7 on the consent calendar, again, are innovation proposals. The first 2 innovation proposals are requests from Monterey and Mariposa counties to join the existing Psychiatric Advanced Directives Phase 2 Multi-County Collaborative. The third innovation proposal is from Orange County and is a request to extend their participation in the Psychiatric Advanced Directives Phase 2 Multi-County Collaborative. That originally received commission approval in August of 2024. The fourth innovation proposal is a new project from Fresno County. This project will provide outreach and engagement, as well as increase access to care for individuals who are homeless or at risk for homelessness and have a serious mental illness, chronic mental illness, and/or substance use disorder. The fifth innovation proposal is from Marin County and is an extension request for their Student Wellness Ambassador Program, which was originally approved by the Commission in September 2021. And the final innovation proposal is a new project from Ventura County and seeks to expand access to comprehensive mental health services for children and transition-aged youth by using the collaborative care and behavioral health integration models, which leverage existing infrastructure and workforce to treat both mental and physical needs. All of these innovation proposals align with the BHSA and include plans for sustainability. Commission staff have sent the documents related to these projects to the commissioners, and a copy of the staff analyses for the proposals have been provided in your packet. Item 8 on the calendar is the Immigrant and Refugee Advocacy Intent to Award. On January 24th of this year, the Commission released a request for proposal to award $502,500 in contracts to each of 7 local organizations to conduct advocacy, training and education, and outreach and engagement activities on behalf of immigrant and refugee populations. The application closed on March 14th, 2025. Today, we're announcing the Commission's intent to award contracts to the following organizations: Asian Americans for Community Involvement, BPSOS Center for Community Advancement, the Center for Empowering Refugees and Immigrants, El Sol Neighborhood Educational Center, Health Education Council, International Rescue Committee, and Refugees Enrichment and Development Association. So congratulations to these awardees, and thank you for your commitment to improving the mental health and well-being of our immigrant and refugee populations. The next item on the calendar is the K-12 Advocacy Notice of Intent to Award. On February 18th of this year, the Commission released a request for proposal to award $2,010,000 to one statewide organization that would conduct state and local level advocacy, training and education and outreach activities on behalf of K-12 student populations. The application closed on April 4th, 2025. We're announcing the Commission's intent to award a contract to the following organization: Youth Leadership Institute. Congratulations, YLI. Looking forward to the advocacy you'll do on behalf of and with K-12 students. The last calendar item is the 0 to 5 Maternal Behavioral Health Notice of Intent to Award. On February 27th of this year, the Commission released a request for application to award $18 million in available Mental Health Wellness Act funds to 6 community-based organizations in order to reduce out-of-home placements, improve educational outcomes, identify developmental delays, and otherwise serve the behavioral health needs of children 0 to 5 and their families. The grants were awarded as follows. 2 small county CBOs will each receive $2 million. 2 medium county CBOs will receive $3 million each. And 2 large county CBOs will each receive $4 million. The application closed on March 28th of this year. Today, we're announcing the Commission's intent to award the following grants. In the small county, Casa de Esperanza and Redwood Community Services. In the medium county, Child Parent Institute and North Marin Community Services. And in the large county, St. John's Community Health Center and Foothill Family Service. Congratulations to these awardees, and thank you for your commitment to advancing the behavioral health needs of birthing people and children 0 to 5. At this time, I'm going to invite our commissioners to offer comments or ask questions about the minutes, any of the innovation proposals, as well as our intents to award in the immigrant and refugee space, the K-12 space, and the 0 to 5 and maternal behavioral health space. Great. Okay, no comments from our commissioners. I will just say, I want to give a huge props, kudos to the commission team for the work to review these applications and ensure that we're communicating the availability of these resources to community organizations. This commission has had a number of discussions about the need to better integrate community-based organizations in our partnerships so that we absolutely work critically with counties, but that we also work with community organizations who are a vital part of our infrastructure to meet the health needs of our communities. And as you heard throughout all of these awards, there are multiple community organizations that are working hand in hand with our county and our state leaders in order to help families get the services that they need to stay healthy. So just really want to give special props and attention to the commission team that makes that happen. These programs are really redefining what it means to have mental health services in our community, defined by our community, in partnership with community, and just really want to applaud those efforts. So thank you.
Chair, if I may?
Yes, please.
I would just like to make comment on the K-12 youth leadership advocacy. I think the team worked really diligently to get that lifted up, and something we've been asking for a very long time. So to have the state group lead that and work with partners across the state. It's something our youth have been asking for. So thank you to the team, and thank you for identifying that group. So greatly appreciate that. Thank you.
Thank you, Commissioner Madrigal-Weiss.
We also have a comment from Commissioner Bear online.
Oh, please. Sorry, I can't see you.
Hi, sorry I'm not there in person. As a new commissioner, I'm just curious about specifically the maternal health care grants. How is the commission getting updated and reporting in the success or not of, just the condition of that, the money and the status updates? How are we as commissioners taking a look at that to track? It's more tracking.
Commissioner Bear, thanks for the question. This is Will Lightbourne, the Interim Executive Director. One of the things that we've been really focused on the last few months in the sort of the reorganization of some of our functions is bringing together sort of our contract teams and our research and evaluation teams to be sure that both as we start to turn these awards into contracts, there are clear expectations and deliverables that lend themselves to evaluation. And then as reports start to, the required reports are coming in from the grantees, we sort of want to be sure that we're not just sort of checking boxes, but rather there's really a look at of the things we intended or expected to accomplish with this. What's the progress being made? What are the difficulties? How can we be of assistance? Can we help them relate with or make connections to other players who are in the area? We're very excited that we're able to launch the initiative, and at the same time, we know that between the Department of Social Services, the Department of Healthcare Services, and other players, First Fives, there are a lot of other sort of initiatives in play, and sort of making sure that what these grantees are able to access in terms of networking, if they need support or assistance in getting there, we want to be sure that we're providing them from the commission staff with that support. And at the same time, we intend to hold them accountable to really give us outcomes that help us learn what works. We're asking them to do things that aren't necessarily 100% for sure successes, but that's the point. We want to support them in trying to knit together a set of resources under the Mental Health Wellness Act and in sort of concert with the Behavioral Health Services Act to make new approaches work. So I don't know if that's responsive to your question.
That is, and as commissioners the accountability is great, but I'm just speaking on behalf of myself. If, as a commissioner, if there are any pockets of connecting dots and getting reports back from these programs, there might be some other low-hanging fruit that, as people in different communities can help support and even elevate what they're doing.
Yes, and sort of not to step ahead of our agenda, but one of the goals we have in proposing, or the chair is going to propose, the creation of a program committee, is to have a group of commissioners to whom the periodic reports from these sorts of grants come in, and perhaps the grantees themselves come in, and we see what we all share in what we're learning and see where we can collectively, not just staff, but commissioners, help people make their connections.
Thank you.
Vice Chair, please.
Again, I think that Will's point is well made, that the committee process, as we've began to advance it, is a great way to not only instruct commissioners at large, but also to ask those critical questions regarding key performance indicators and whether or not the fiscal elements of a proposal are being fulfilled. from my vantage point, Will, oftentimes when I was a part of a community-based organization, there would be a blend of funding associated with some of the examples that you just described. The commission typically, I would assume, provides funding that is like that for a community-based organization in one specific example. Yet, we still want those organizations to report back to, again, as you said, our program committee, and let them know this is how we're doing. Because in a previous role, that was an inculcated feature of what we had to do in order to keep the money. And we had to do it quarterly. And it's more than just a report card with checking off boxes. It really is more of a narrative, and oftentimes it even involves providing perspective from the people that we were encountering or serving regarding service delivery. So looking forward to that. I look forward to seeing how the committee, that particular committee, can bring back reports to the larger commission that will help advance what Commissioner Bayer just said.
Thank you, Vice Chair, and thank you, Commissioner Baer. I really appreciate that this discussion and the unique role that this commission plays in trying to best connect those dots and make that map or network of resources across our state agencies available as one system for the people that we seek to serve. It doesn't matter, what agency funds an initiative to a mom who is having postpartum depression. She just needs the services. And so I really appreciate you highlighting that and the opportunity that the commission has to advance that. With that, Mariani will open it up for public comment, please.
We do not have any in-room public comment. We also do not have any virtual public comment.
Okay, thank you. Now that public comment has closed, I would entertain the motion on the screen so that I don't have to read each one. Is there a motion?
So moved.
Thank you, Commissioner.
Second.
Thank you, Commissioner Gordon. We have a motion and a second, Sandra. Are there any additional questions or comments from commissioners?
And I have the motion from Bontrager, the seconding from
Gordon.
Gordon, thank you so much. I will now proceed with roll and ask the commissioners joining us online to unmute their lines at this time and have their camera on if they are participating in voting. Thank you. Commissioner Baer,
Yes.
Commissioner Bernick,
Yes.
Commissioner Bontrager,
Yes.
Commissioner Brown, Commissioner Bunch, Commissioner Callan,
Yes.
Commissioner Carnevale,
Aye.
Commissioner Chambers, Commissioner Contreras,
Aye.
Commissioner Designee Swartz, Commissioner Cross,
Aye.
Commissioner Fairweather, Commissioner Fernandez,
Aye.
Commissioner Gordon,
Aye.
Commissioner Designee Bulmano, Commissioner Larson, Commissioner Madrigal Weiss,
Yes.
Commissioner Mitchell,
Approved.
Commissioner Robinson, Commissioner Southard, Commissioner Sy,
Aye.
Commissioner Wilkies,
Abstain.
Vice Chair Roulette,
Aye.
Chair Alvarez.
Aye.
The motion passes.
Thank you. Moving on to agenda item 5, the advocacy spotlight. As a reminder, at each of our meetings, we are inviting one of our contracted advocacy organizations to share with the commission the work that's happening around advocacy with and on behalf of marginalized and often underserved communities. The commission has advocacy contracts with organizations that represent the needs of consumers, diverse racial and ethnic communities, families of consumers, immigrants and refugees, K through 12 students, LGBTQ communities, parents and caregivers, transition age youth, and veterans. All of these groups have unique challenges when attempting to access behavioral health resources, so these contracts are provided to ensure that the interests of these groups are represented in local behavioral health planning and state-level policymaking. To accomplish this work, the organizations conduct advocacy activities, training, outreach, education, and engagement events around the state. So the intent to award organizations that we just listed, there's opportunity to hear from them in the future. So looking forward to those opportunities. For today, our advocacy spotlight is focused on the exciting work that's happening with CalVoices, in particular for our client and consumer communities. So thank you. I'm inviting Claire Courtwright, Advocacy Director, and Nicole Chilton, Program Manager from CalVoices. If I mispronounce your name, please correct me. It's important to get that right. So thank you, Claire and Nicole, for being with us, for your time, and for sharing a little bit more about the work that you all are doing with our communities. Go ahead.
Thank you so much, Commissioner Alvarez, for that kind introduction. I am Claire Courtwright. I am the Advocacy Director at CalVoices. And we would really like to thank you for letting us come and present today. This advocacy grant lets us do critical work, and I think we've been really good stewards of those funds, and we're excited to show you what we've been doing. For the new commissioners who might not be familiar with us, CalVoices is a consumer-operated organization, sometimes called peer-run. So we are run by and for people with mental illness. I'm a person with lived experience. 98% of our staff are either clients or family members of those with lived experience. And we run direct peer support programs in these northern counties that are listed. We're also a state recognized trainer of Medi-Cal certified peer support specialists, and we do education, technical assistance, and advocacy both at the state and local level. Our mission is to represent the self-identified needs and priorities of the client and consumer population. And we've been at this for quite a while. I'll let you guys review the wordiness later. In 2017, we started the Access California program at CalVoices, and it was funded by this commission to empower advocacy by the client consumer population at the local level. So the client consumer population is distinct from peers. We're the population of people who are direct service recipients in the public behavioral health system. So that's primarily been folks with the more acute diagnoses that are in the specialty mental health programs and things funded through the BHSA. So within that core group, client consumer, we are as diverse as humanity itself. And so it's a challenge for us to figure out how do you support the client consumer population in all of their diversity. And so we're doing that by some general strategies that involve leading from behind. We spend time on this grant learning ourselves about the very complex state and now even federal and local policy issues that consumers and clients need to understand in order to meaningfully engage in advocacy. We then teach those elements to our population in interactive ways. And then we empower implementing what has been learned by showing people where the access points are for local advocacy and the opportunities, and also assisting clients and consumers in accessing state level forums. So we'll do public comments to major regulations and that kind of thing on behalf of the community. And then the cycle sort of repeats. We communicate advocacy outcomes back to the community. We learn from the community. And the ultimate goal in this cycle of this grant is to support people in the upcoming community planning process for BHSA. So our general strategies for outreach to our community are organizational and individual. On an organizational level, when we partner with folks on this grant, we are looking for organizations that are consumer operated and that are dedicated either to direct service provision of people with mental illness or SUD, and also folks, their leadership is representing the major intersections of new behavioral health policies. So some of our LLEs are organizations that are run by and for people with mental illness, people with substance use disorders, people who are formerly incarcerated, people who are formerly or currently unhoused, rural communities, legal aid, and more. Our strategies to reach individual clients and consumer members of our population is really in the way that we create the forums that we have created under this grant. So we're looking to create forums that really respect the lived expertise. It is a body of knowledge to live with a disability. So we create those forums that respect the lived expertise of individual members of our community, that promote advocacy and self-advocacy in systems as a way to recover from mental illness and substance use disorders, that really celebrate that grassroots leadership that does exist in our community. And we make these forums accessible. Many members of our community live at or below the poverty line. They live with serious disabilities. Many of them are currently unhoused, and so we're always looking for strategies to bring those people in. And one of the ways that we've done that is travel stipends. We go around to different regions of the state. We want people to be able to be there in community and in person, so we finance that for them. We help them get there. We've also done, we're also significantly trying to do outreach to the substance use disorder community that's kind of being brought in at this transition point. And so we've done outreach to alcohol and drug advisory boards, to rural county mental health boards, AOD boards. And then, this cycle of kind of learn, teach, implement, we've analyzed pending legislation, regulations, developments in Medicaid and Medi-Cal. We learned how various pieces of policy and law fit and work together, and how policymakers think about these issues, and we identify where the opportunities for advocacy actually exist. What can you guys change versus what's set? And we learn bottom up from the community. We hold those regional trainings and networking events where we get to know folks and what's going on in their locales. And then we conduct a lot of surveys of our participants and attendees where we learn to vary our content, vary the educational level that might be needed to understand it, give overviews, make content shorter or more interactive. So we respond and change when community members tell us what they need to be brought into the process. And we create forums that are question and answer, and individual members of the community reach out to us for technical assistance. So as part of learning from the community, we conducted our first annual survey of the peer workforce. We have hundreds of responses to this, and we learned that many peers are not Medi-Cal certified and or work in programs that are not set up currently to bill Medi-Cal, and these peers could be left behind because one of the big transitions under Prop 1 is really to be more Medi-Cal billable. So we identified that as a major issue facing the community, and we've done some things I'll talk about in the implement section to respond to that. And it's Nicole's turn.
All right, so for our teaching element, we kicked off the teaching component of our grant. Oh, thank you. We kicked off the teaching component of our grant work with our partner organizations who represent intersectional lived experience and multiple disciplines. Consumer-operated direct service providers, advocacy agencies, legal aid, community organizers, and patient advocates. We taught the history of law and policy and discussed contemporary issues impacting the consumer population we serve. Every quarter, we hold public policy updates and training webinars that keep the community informed of law and policy changes. We cover current events that impact consumers in the public health system. How is peer support financed and how may that change? What is happening at the federal level with potential Medicaid cuts and how might consumers be impacted? We also produce podcasts that make policy accessible through conversation and discussion. We held an annual statewide conference in February, attended by 250 people, that brought together county behavioral health directors, community-based organizations, grassroots leaders, and intersectional lived expertise, and state policy advisors. As a group, we taught, learned, and listened regarding the unmet needs of consumers and how systems can better serve them.
So now I'd like to turn to how we implemented what we learned and how we supported the community in their needs. Access has provided technical assistance to consumers and consumer-operated services, especially those currently funded through MHSA that are facing this transition, by drafting detailed proposed regulations to the Behavioral Health Services Act, Medi-Cal state plan amendments, behavioral health information notices, because we're looking for those substantive rules that are going to support these advocacy goals, and also the necessary clarifications to the law so people understand what's changing and how they will be impacted. And that allows consumers and consumer-operated services to meaningfully engage in the community planning process. So I'll give you an example of what that means. We're familiar with money moved out of services and into housing under BHSA, but the subcomponents where people's funding actually exists was shuffled a little more like a deck of cards. So one of the things we're trying to do for the community is identify where is your card now, right? Where's the affirmative authorization for your program or service, and what money is associated with it. So those are some of the things that we've been doing. We drafted dozens of proposed regulations, probably about 100 pages of public comment. And all of that is to help the community and individuals prepare for the community planning process, understand what the new rules of the road are. Many of our regulatory asks are pending, but some have been granted. We got the law clarified so people understand what is a regulation and what is a policy that can change, because there is a difference. We asked for, and we're waiting to see if we obtained rules that will preserve and expand consumer-operated services like wellness and recovery centers that are not currently Medi-Cal billable models. We also asked for the preservation and expansion of peer support and peer roles. We're still working with DHCS around some of that. Something that I'm very proud of, we asked for a grandfathering clause in the Mental Health Services Act around housing, because the eligibility rules and allowable settings for housing are changing as you go from MHSA to BHSA, and we did not want anyone to lose housing as a result of the complexities on both sides for eligibility criteria. We asked DHCS to give us a grandfathering clause that says anybody who is housed through MHSA at the changeover to BHSA will continue to remain eligible without a redetermination. And we got that. So we're very proud of that and pleased that DHCS worked with us on that. And we've done a good job according to our community, but we're always trying to do better. These are some of the feedback that we received from events that we've held, because we do survey all of our attendees. And I think, for our annual statewide conference, it was especially responsive to the needs of the community, because they said, you guys are doing like graduate level kind of analysis sometimes, and we want more of an overview. What is behavioral health transformation? How do the pieces fit together? How will I likely be impacted? And so we really tried to do that for the annual statewide conference. And I think like 71% of our attendees said our content was excellent, and another 30% said it was pretty good. So we're working hard to be responsive to the community. I think I'm a little over time. I do have a video. It should play. I might need assistance making it play.
Hi, everyone. My name is Angel Mercado. My pronouns are she, her, hers. I am currently 24 years old, very proud to be a peer from my direct experience and a peer via family member experience. I've been in my own personal recovery for about almost 5.5 years now, and very honored and blessed to be a part of the Painted Brain team, which gets to work with Access. I'd say first and foremost, as an individual, I've really loved working with the Access team. I feel that it's so important to continue having peer spaces where we can connect with one another. I know that for myself, I feel like I'm very much a rookie in the game when it comes to advocacy and peer work and understanding. Like, I hopped into this learning about support groups, seeking my own recovery, not knowing everything that goes on, like in regards to mental health and substance use disorder, and like with Prop 1. These are all things that, like, I was just a person trying to get better. I didn't have the mental capacity to figure out legislation and this and that. Like, my mind was so far beyond that. And it's been really empowering directly as a consumer to know, like, the state that I'm in, the things that are going on in my area, and feeling empowered that I can do something about it. And that is, a big part of like why I personally love Access so much. That bleeds into my professional life, where I've been working with Painted Brain for about 4 years now, I would say. I'm currently a peer trainer, students going through peer certification process, thanks to SB 803. And as a trainer, I will say hands down, so empowering for my students to let them know, this is the work that you'll be doing, like to be informed of what's going on, the systems that you're going to encounter, the people that you support, what types of challenges are going to come up as legislation moves and changes. And I think it's so deeply important, and it speaks so deeply to my heart, the sense that a majority of my peers, some folks already established in other careers, but so many, this is their first job in a long time. And like the fact that we have a training with scholarship funding and allows them, like a step in, pure jobs are so important. And to let folks know, it's like you can defend this job that you're so interested in getting into. And we've been learning more about the community health worker role, thanks to Access, and like how Access has given me the opportunity to tell the people that I love and support, it's like we're peers. We persevere, we find a way, and like with the model that we have now, we can directly impact it. If things switch up, there's also other roles available. And like when we feel disempowered, having the knowledge to know that we do have power and we can continue. So as a person of direct experience, as a family member, as a trainer who loves, every single one of the students that goes through our training, Access has been just a deep, deep blessing to our team. So I think, Access, I thank everyone who allows us to be a possibility. And thank you for your time.
I screwed up by not properly introducing the fabulous Angel Mercado that you just heard from. But these are the grassroots leaders that we're talking about, the people that are out there implementing and really binding the community together and using this work to do that. I think we were asked for a couple of recommendations that the commission might consider if to support this work on an ongoing basis. And it really is continuing these grants through the commission, the ongoing support for the stakeholder advocacy and extensions of those. I was pleased to hear Commissioner Alvarez talk about that and bringing in the community-based organizations. I will say a need that the commission might be able to advocate for at the state level is that these smaller organizations that have been funded through the Mental Health Services Act are funded outside of the health insurance model. And trying to bring them into the health insurance model is difficult. There's financial barriers, but there's also just a lot of need for technical assistance to organizations for them to have continued sustainability as more of the systems move inside of health insurance. So that's something that the commission could advocate for or help us with. And we are also looking to find ways to integrate peers, so people with lived experience that are acting as providers to each other. It is a Medi-Cal billable model. And we're looking for ways to integrate these folks into us, into more of the continuum of care. We are siloed in the public behavioral health system, in specialty mental health for the most acute diagnoses, and we'd like to be more places in the system. Thank you so much for your time and being patient with me, because I think I'm a little over time.
Thank you, Claire and Nicole, for your time and for sharing a bit more about your advocacy and for the space that you gave Angel. I think that was a clear representation of the work that you do and how it impacts people. So thank you so much. At this time, I'm going to invite our commissioners to offer comments or ask questions. I see Commissioner Chambers, Commissioner Fairweather, Commissioner Mitchell. Commissioner Bontrager.
I'll try to be quick because I always got to comment and be commenting all day. I am biased because Angel is one of I'm honored to work with her, and I'm honored to be an individual with lived experience that is working in the mental health system and showing that recovery is possible. I am thankful for you all for demonstrating the expertise that you have empowered us as consumer-run organizations to understand the policy landscape, understand our power and our ability to advocate, and to be able to inform the utilizers of the system of what's going on or what's going to happen with our services. At the end of the day, that's really what it is, being able to support people in recovery, and that's what this workforce does. And the commission, I want to just continue to uplift the importance, like I said, of projects like this that be able to support the community to understand what's going on. And I just want to thank you, and I'm just proud to be a part of the network and to be able to better understand my rights, understand how to better be a practitioner of this service, and I'm honored to be here with you. Thank you.
Thank you, Commissioner Chambers. Commissioner Fairweather.
Wonderful work, very impressive. I wanted to ask a little bit about your second recommendation about the billable hours. In my experience, smaller community-based organizations do not have the capacity to be able to do any kind of billing, Medicare billing or other, and they are so necessary to the community care if they're representing smaller populations, including veterans. It seems to me, I don't know because I'm new on the commission, but in terms of encouraging counties and full service providers and others to subcontract and to actually take care of that billing process, because we can't even get to the tipping point where it makes sense to develop the capacity, whether that's IT, individuals, et cetera. So it's really key to keep the work out there with the peers and the face-to-face direct services, especially to underserved populations. So, and thank you again for your presentation. It was great.
Yeah, I'll just add a comment if I may. We agree it's a real challenge for the small organizations to try to have the infrastructure to get inside of Medi-Cal. People are trying, and I think we've had to sort of, smaller consumer-run organizations are sort of relying on each other to the extent that we can learn things and offer technical assistance to each other to see, if we do have the capacity or we can pull together somehow to have the capacity and look for those avenues. So we are still, whether or not people can make it, but we still want the technical assistance a little bit for people to know on a long-term, basis. But you're so right that the barriers are very high.
I would also add with regard to CalAIM, because that's it confuses me, so yeah.
Thank you, Commissioner Fairweather. No shortage of opportunity, absolutely. Commissioner Mitchell and then Commissioner Bontrager.
I just wanted to thank you for the presentation. I love the video because it really shows that this is what it's all about. And to Commissioner Chambers, recovery does happen, healing happens. And so just to have someone, just present like that is very encouraging. It's courageous on her part. And for your organization to help create that that new person. So that's really the goal of what we do. So I just love that. And there are just so many areas of opportunity. I also am a certified peer specialist. And so there are opportunities for moving peer specialists into more of the mainstream model of the work. And so you guys are doing so much of that. So I just really wanted to thank you because it was just a beautiful put together presentation. Very, very well done.
Thanks, Commissioner Mitchell. Commissioner Bontrager.
Thank you for the presentation. I wonder with the new requirements for counties to engage in this robust stakeholder involvement in their county planning, and there's probably 36 identified stakeholders that have to participate or should participate. Is there some capacity for your organization to provide technical assistance or best practices to our counties to say, how do you best engage stakeholders in this process? So it's not just symbolic, it's actually meaningful?
Yeah, absolutely. I think even going back to 2017, when this access program started at CalVoices, a core component of it was actually training around the community planning process and how to engage in it. Right now, everyone is trying to get those pieces into place, and we will continue as part of this grant work to absolutely train folks on how to engage in the community planning process. But we're also waiting on the Department of Healthcare Services just put out some draft regulations around what that process is going to look like, and I believe there are some counties also working on guidance. So, we do offer public comment, and then when some of those pieces are certain, then it's we're able to give more specific guidance to people. I don't know if that's responsive, but
Yeah, I would like to flip it on its head, though. I mean, I understand that you're training peers to engage. I actually think our system, the counties, and our system needs to know a best practice and approach to how to engage these stakeholders in the process. Quite the opposite.
Oh, I did not fully appreciate what you were saying. I think that's absolutely correct. I think that's correct that, decision makers could also use some top-down, advice from the community about how to engage us.
Love that. Thank you, Commissioner Bontrager. Commissioner Carnevale, please. And then Rolette, Madrigal-Weiss, and Gordon.
Thank you, Madam Chair. From my viewpoint, the peer support was new as I came into the commission, and I've tried to educate myself to learn so much. And one of the things I've learned is how much good work CalVoices does amongst many other organizations. From my particular viewpoint, when I think about it strategically and financially, to me, this just makes so much sense for so many reasons. And I'll, as I stand up more work on sustainable finance, which I commented on a couple of meetings ago and will be doing more with, I'll certainly be leaning in that direction financially. But more broadly, what jumps out at me is that I think I would like staff to look at doing a paper on this. I think we need a broader landscape understanding of peer support, what the landscape looks like across the state, where we should be leaning in, best practices, county, all of these questions. I would like to see some broader paper so we can really fully understand this rather than kind of piecemeal it. So that would be a recommendation I would make.
Well, you'll get a snippet of that when we talk about legislation today.
More than a snippet. We will also see in the summary of concepts being raised for the Innovation Partnership Fund, there's a strong emphasis on what can be done to really build out the full inclusion of peer support specialists in sort of the integrated health delivery system.
Thank you, Commissioner Carnevale. Vice Chair Rolette, Commissioner Madrigal-Weiss, Commissioner Gordon, Commissioner Tsai, and then Commissioner Wilkes. Vice Chair.
So you all are well known for your advocacy in the area of working with people with lived experience and people who are consumers of public mental health services. I want to acknowledge that. I also want to acknowledge that you in your advocacy oftentimes work with counties and DHCS, as you illustrated in your example, very effectively. And it's a sort of a preamble, so get ready, okay? But Population Health Management and CalAIM identified another service system or service area or service provider, better, and that's the private insurance industry. And Commissioner Bontrager and I have had lots of conversations about that. And under CalAIM, ECM and CS is an important component. And yet we hear various comments about the overall appreciation about people who are in recovery, who may be identified as having mild to moderate symptoms, and being able to access that insurance coverage. And so it would be intriguing to me for the commission to take a look at that, not to punish. I'm going to reassure my fellow Commissioner Bontrager that's not my goal, but to really talk about effectiveness of service delivery and how to better engage and help the private industry to understand what some of the needs are for people who are experiencing mild to moderate symptoms. I'm intrigued by that. I'm intrigued by the commission having a role with that, and I want to hear what your thoughts are about that.
So I'm not, it might be a little bit above my, my understanding. Did you mean the private insurers that are providing Medi-Cal services or fully outside of the public
The
system?
private insurance industry that funds ECM and CS services. And those services are available, albeit to people who are experiencing mild to moderate symptoms, if they have that coverage.
Yeah.
And with their Medi-Cal.
Yes.
Yes.
Yeah, I mean, we're very much in favor of seeing greater services on the managed care side too. I think the kind of platinum plan has always been on the county side in terms of, you know, the variety and intensity of services, and that there is a need for some parity. And I mean, just across the spectrum of mental health services, there's a need for greater support. So yeah, we're definitely interested in seeing the commercial plans embrace some of these expansions, including integrating peers and people with lived experience, you know, into that side of the system. And I think that's what some of the community-based organizations are looking at, being ECM providers within the managed care structure. And, you know, tying that, trying to get as many benefits as possible for a person with the expansions in community supports as well. But I mean, I don't run an organization, so I'm just a little bit, you know, the super technicals on it are above my head, but we agree that there's a need to, you know, have greater support for folks in the mild to moderate side of the house and spectrum and in managed care.
I'll conclude my comments by saying I agree. I think that oftentimes the public system and the managed care system, the public system provides what is platinum, considered platinum care in behavioral health, and it should be platinum care across the spectrum.
Absolutely.
Thank you, Vice Chair Rolette. Commissioner Madrigal-Weiss.
Thank you. I just wanted to thank you for your presentation. I learned a lot. And, you know, since I've been on this commission, I have had great teachers, Katera, Tina, Rachel, Stacy, as they share their comments. And I have really come to have a great appreciation for the work and the work of peers. And I would just ask, I like what Commissioner Carnevale said about a paper, because I would like to see us be intentional with our youth too. We talk about peer programming, but there really is no set definition to really embed best practices in it. It goes with whatever curriculum is there. And I think we could do better because our youth have a lot of lived experience, and who better to support than other youth, right? Exactly what we're talking about, peers to peers. So, so maybe consider that. I don't want to add more, but I think we can be intentional about supporting it as well. So thank you for being here and sharing your expertise with us.
Thank you.
Thank you. Thank you, Commissioner Madrigal-Weiss. Commissioner Gordon, please.
Thank you, and I want to add my thanks to you for your presentation today. And I'd like to put some questions before you, not to answer now or talk about now, but to think about for the future. So as a person who also, like Commissioner Madrigal-Weiss, works in education and it has lived experience, I think we're really missing the boat on prevention. We don't do nearly enough prevention. We squeeze prevention in. So just to give an example now, CalAIM is doing a very smart thing. And they're asking all the first 5 commissions to do MOUs with the managed care organizations about how they're serving the 0 to 5 space. Well, it's fine to have an MOU, but we need a much more powerful vehicle for saying in the 0 to 5 space, before kids even get to kindergarten, there are so many things that can be done to make their futures better before they even get to school. And so, to Commissioner Carnevale's point, I think in addition to studying the importance of peers and families and so on, we need to study this merging of the education system and the health system to make sure that we're really, really putting more muscle behind prevention, because the dramatic difference in what an underserved family gets and a well-off family gets is so dramatic. And the analogy that comes to mind is far from a perfect analogy, but if you could think about ways, when you talk about the nonprofit agencies not having much capacity to do the billing, well, think about a school district doesn't have much capacity to do the billing. That's a big problem right now as we roll out this fee schedule. So the analogy I give you is if we have a feeding program for young people to make sure that they get a breakfast and they get some nutritious meals, what do? The kids don't turn in their addresses and their social security numbers and all of that. If we did that, nobody would eat anything. So what we do is we fund a school with a high proportion of needy students and say everybody will eat in the interest of getting to the younger people and getting the prevention agenda advanced. So I'd just like you to think about on that note, because I think we ought to do a study of that system also, along with the power of peers, which I think is dramatic. So thank you for listening, but think about those things. I'd really be anxious to hear your feedback.
Thanks, I really appreciate that, Commissioner Gordon. Two very big items being lifted up here, like the role of peers and also the need to build capacity to bring in community leaders and organizations into our system. So again, no shortage of work, but a lot of commitment and leadership on behalf of this commission. Commissioner Tsai.
Thank you, Chair. Thank you. As a great presentation, as mentioned by my fellow commissioners. A question on your second recommendation. I'm very familiar with our specialty substance use system, and we have a majority of a workforce that have lived experience. And I'm very familiar with this tension between how we can benefit from some of the standards and the financial benefits of Medi-Cal, and balancing that with trying to create a simple way for us to actually benefit from Medi-Cal. Can you talk a little bit more about, in the TA that you provide to try to make these complex processes simpler, what are some of the key pain points, just so that we can better understand, how best to navigate that tension?
Sure, yeah. I've done myself a disservice by putting this recommendation in here because it's really my executive director and my general counsel that know the technicals. So I did not do a good kindness to myself here. But I will say, I think I can speak to some of the pain points, right? So right now we have brick and mortar locations that are cash financed through MHSA that are they have never been inside the insurance model. So we have like wellness and recovery centers. We have drop-in centers. And so one of the challenges is you operate a brick and mortar location, you want to become Medi-Cal billable, you have to get site certified. Well, how the heck do we do that? Is it expensive? And even if we get site certified, the practices that we have now, where do they fit in billability? Are our providers credentialed to be able to bill Medi-Cal? That's a big issue right now because a lot of our peers are not Medi-Cal certified because they've been able to be cash financed essentially outside of Medi-Cal. And then, figuring out kind of, I know for organizations that are looking at being ECM providers, you've got to come up with policies and procedures. There's just a lot of stuff like that. And many of the organizations that are smaller and are consumer operated, so run by and for people with mental illness, have been used to having a much more simplified process outside of health insurance. And so, yeah, it's okay. What do I have to do to get site certified? What can I bill for? What do those reimbursement rates look like? Because in MHSA, it's like you're able to get funding for any actual operating costs, and then operating in a different system where it's based on provider rates is much more complicated, and sometimes there's uncovered costs. So that's about the extent of my knowledge. Mm-hmm.
Thank you, Chair, and thank you for the presentation and the work that y'all doing at CalVoices. Peer support specialist is my jam. When it comes to credentialing, so I have some questions. Credentialing, there is a credential that comes with becoming peer certified, right? But they can't bill, especially if they're under the age of 18, right?
Yeah, so I think that's correct. I think that I realized they changed it to CMPSS, so Certified Medi-Cal Peer Support Specialist. That's an adult designation. I'm used to the adult system, so I don't think that there's a credential for youth at this time. And then the other sort of lived experience paraprofessional recognized in Medi-Cal is CHWs, and Nicole is much more the expert in community health workers than I am. But yeah, you're correct. I don't believe that there's any credential for people under the age of 18.
Okay, so we'll love to see the advocacy on that front to help with, as kind of the establishing relationships for prevention, as some of the commissioners have talked about. And so my other question is there an encouragement of dual credentialing?
Dual credentialing between.
So if a peer support specialist, or whatever the new terminology is being used now, because we got to keep up with that too, for them becoming a peer specialist, and if they have, I think it's 2,000 hours for CHW, if they have that, could they be dual certified to be able to capitalize on the billing part of things?
Yeah, so there'll be some more discussion. I'll let the deep dive, I'll leave the deep dive on that conversation for this afternoon. Everyone's chuckling.
Okay.
There is a deep dive this afternoon, but you're correct, right? So it's just an oddness that the federal government architected, peer support specialists as a lived experience paraprofessional type first, and then created a much broader lived experience paraprofessional type with CHW. And so, yeah, this is kind of an outstanding question. Do we need two different credentials or one? But as to your question, yes, a person with lived experience of mental illness or substance use disorder does have the relevant lived experience to be dual certified as a peer support specialist and a community health worker.
Okay, and y'all encourage that when
Yes.
y'all, okay, beautiful. That's it.
Thank you, Commissioner Wilkes. Such great points. I feel like I have 7,000 things to respond to that, but I'm not going to. Commissioner Fernandez.
Thank you, Chair. And the presentation today from CalVoices today was fantastic. So thank you so much. It's been a pleasure learning more about your organization. I'm curious to know, sort of, as BHSA evolves and rolls out, when I learn more about what peer support specialists are doing in the state of California, the timeline that peer support specialists have had to mature in a primary mental health system versus what we're dealing with today, I'm interested to know how an entity like CalVoices that has such deep roots working with mental health peer support specialists, but is today offering peer support training for the Medi-Cal peer support specialists, has either geared or maybe changed some of those training programs to more adequately address the needs of persons who have substance use disorder conditions and not only mental health disorders?
That is such a great question. Some of the organizations that we're working with, so I'll give a little bit of a history. I have not seen, I could be incorrect, but I have not seen you do not find, and it's partially because there's other provider types, and I think Commissioner Tsai could probably speak to it. Technically, Medi-Cal does allow for a person with lived experience of substance use disorder only to be a peer support specialist. But the way that California, when it opted in at the federal level to allowing peer support to be billable in its Medi-Cal program, actually passed the option to opt in from the state down to the counties. It's kind of technical, but basically they did that for budgetary reasons. It means the counties pay for the non-federal share of cost on that and not the state general fund. But the result of that was counties using the Mental Health Services Act for the non-federal share of cost, and up until it changes over to BHSA, that's restricted to the population with serious mental illness. So essentially there wasn't really, because of the county opt-in model in the bill that gave us Medi-Cal billable peer support specialists, there really hasn't been a ton of equity with substance use disorder. You're correct about that. And some of the organizations that we've done outreach with and we're trying to work with are interested in curriculum more tied to substance use disorders, because now that this funding stream is opened up, there's a potential source for the non-federal share of cost for SUD peers. Great question. Yes, we are looking at that.
Thank you.
Thank you very much. Okay, I think our commissioner comments and questions have concluded. Again, this has been a really robust conversation about some huge challenges, but also huge opportunities to improve the delivery of behavioral health services. So hugely appreciate, you're not done yet because we still have public comment, but just really want to thank you for the conversation and discussion and the work that you all are doing. And on the youth side, there is youth peer-to-peer programs throughout California invested in by the CYBHI. Full transparency, my organization is in a partnership with DHCS at 8 high schools. Would love to share more about that, Commissioner. There is such opportunity to meet the needs of communities by uplifting the expertise and wisdom of our people. So this conversation highlights that, and I look forward to what the work of this commission to move that forward and make it a reality. So thank you again. Let's open it up for public comment, Mariani.
We currently have 3 virtual comments. Our first comment is from Richard. Your line is open.
Good morning, everyone. This is Richard Gallo from Santa Cruz County. I just want to thank CalVoices for their active role in teaching consumers how to become advocates and how to understand the system and how it works. I am a participant. I've been a participant since the beginning of their initial grant of Access California as part of CalVoices. And that's why I'm here today still, even though the project has changed. But I'm giving you my feedback, my suggestions, my concerns on behalf as an individual, as a consumer, but also on behalf of the mental health community, those that don't have a voice, that are not able to speak to. And the initial grant, they did provide some trainings to counties that chose to get involved with the training. There were a lot of counties that chose not to take advantage of it. My county participated, yet there was no staff there. County staff participated in training to learn about the nuts and bolts of the CPP process. Santa Cruz County is one of many counties like San Diego counties that don't have the buy-in to do what needs to be done to serve the consumers and families. And that's what the commission needs to recognize and still need to recognize with these changes that are coming. You have a lot of behavioral health directors that don't want the CPP to be part of the new behavioral health relating to Proposition 1. They want out. They want the old way. They want to do the old way. They have no intention of supporting the advisory board or the commission with the CPP process. And that's why it partly failed with MHSA, which is why the state decided to do the changes that needed to be made. That's why I was being vocal with the commission, reminding you how counties are choosing not to listen, not to buy in with the CPP process. So it's about being more mindful. It's about taking a stand with the consumers, with the families, so that the money is well invested instead of doing the county old ways when those old ways don't work. So that's all my feedback is. And I appreciate CalVoices for their ongoing advocacy, support, technical assistance, and trainings that they do. Thank you.
Thank you, Richard.
Thank you. Our next comment is from Steve. Your line is open.
Thank you very much. This is Steve McNally from Orange County. As I mentioned earlier, I have a
I'm a parent of a son with schizophrenia. I'm also on a local board, but I'm speaking as an individual. I'll tell you one thing about CalVoices is it listens, it educates, it collaborates, and it builds partnerships. And having been to a lot of meetings across the state, across counties, across agencies in the state, silo breaking is so hard. And some of this comments today by the commissioners, I'm so glad to see you engaged with peers. Silo breaking starts with influence. And even when I started to read the recent modules that are going on right now, it seems like we're looking at maybe mental health and substance use, but we're not really looking at managed care and then uh, the providers within DHCS versus realignment, all these different areas that are all interconnected with funding. And as the general funds go down, it's going to be very difficult, particularly in law enforcement. And it's going to be easy for people to creep over maybe and to look for money. What I'm going to ask for is two things. One is community planning is not a new concept. It was in the original MHSA. It's 5% of received funds. So for every 100 million a county gets, they can spend 5 million. It aggregates to 100 million. We could have been spending that for the last 5 years. It's no secret across the state. And we haven't done it. No one's organized it. Nobody's forced it. And consequently, we've got a change in funding through a proposition. It's be very difficult for people to get involved with community planning. A lot of the communities have given up. There's no trust. And so when the influence meets the facts, change will happen. But a lot of times the people, the facts, don't have access to influence, and influence doesn't come down. So if any of the commissioners are, I'm going to send a note to the commission. If any of you are interested in knowing how to organize yourself from top to bottom in your communities and focus on the 4 counties of LA that share one media market and 45% of California, we could certainly be having town halls at California Endowment, and that gets you in LA, Sacramento, and Oakland if you really are interested in organizing the state. And the last is they're going to leave it for the end on AB 96, but that's critical.
Thank you, Steve. Your time is up.
That's critical to the success of peers in California, as budgets at the counties are going to be diminished and managed healthcare is going to play much larger roles. Thank you.
Thank you. Our next comment is from Mark. Your line is open.
Hi, this is Mark Carmatch again. I'm with the Los Angeles County is going to have its community planning team meeting tomorrow at 9:30 in the morning, and I think that CalVoices and other organizations statewide might want to be a part of that. It's going to be on the internet and on Teams, and I think I can send some of that stuff to the Oversight and Accountability Commission and to CalVoices possibly. In fact, I network with them. I send stuff to CalVoices all the time. So if they want to be a part of that meeting, that's going to be taking place tomorrow morning. And I think possibly because they've been dealing with substance abuse and stuff like that. And we also have what's called adversary and leadership team meetings that our department puts on. And there needs to be participation there. Thank you very much. Appreciate it. I'm done for right now. And I may have some announcements later on.
Thank you.
Thank you.
Thank you. Our next comment is from Laurel. Your line is open.
Good morning.
I'm Laurel Ben Hamida from Mass Social Services Foundation and REMCO, the Reducing Mental Health Disparities Coalition. First, thank you to CalVoices. You provided my peer training, so many other trainings, webinars. You're a treasure. So then on to the complexity of billing question. And I think about this like I think about the housing problem in California. To prevent a bad thing, badly built buildings maybe, to prevent fraud and corruption, what's come into existence is a system that is so complex, it penalizes the community-based nonprofit organizations and the people they serve. So it's a good idea, but the consequences have been terrible and are terrible. We need to simplify the system. Maybe it's too much for mere humans. Maybe it needs the help of artificial intelligence. I don't know. Or just good old-fashioned common sense. But the risk management has erred too far in one direction, for sure. So some suggestions are that the new commission, the Behavioral Health Commission, look at grants and staffing, grants to community-based nonprofit organizations. I'm not saying profit, because you have Sutter, it's nonprofit maybe, or Kaiser's nonprofit. No, they don't need the help. But community-based organizations need the help. They need technical assistance for free. They need grants. And that would be a really, really good use of some of the funds that you can access much more easily than community-based organizations. So thank you very much.
Thank you. Our next comment is from Iswarula. Your line is open.
Good morning. Thank you very much. This is Isratullah. This is Dr. Isratullah Mohammed. I'm a clinical psychologist and systems equity strategist. Earlier this month, I submitted public comment to the Behavioral Health Commission, introducing a framework called the Bureau Care to Custody Cemetery Pipeline. It's a model designed to diagnose and disrupt the very structural fragmentation and complexity raised here today. This framework has already informed oversight improvements across divisions within Los Angeles County, yet it was developed independently and submitted under conditions of professional exclusion. It identifies how administrative burden and procedural fragmentation function as systemic barriers to access, equity, and safety. My comment today is not only about systems design, but about systems ethics. When clinicians and system-impacted professionals contribute frameworks that drive policy transformation, inclusion and attribution are not optional. They are accountability mechanisms. I respectfully urge the Commission to ensure that public frameworks guiding transformation are implemented with transparency, author engagement, and fidelity to purpose. I respectfully urge the Commission accordingly, because the question is not whether innovation is possible, but whether our institutions will act with the integrity to do it, collaboratively, not quietly. So again, it's the emphasis on collaboration, not silent adoption. Thank you for your commitment to equity and for centering both lived and clinical experience in the path forward. Thank you very much.
Our next comment is from Jerry. Your line is open.
Hi there. Thank you once again, Jerry Hall with BHAB Rehab in San Diego County. And I've been involved with CalVoices for several years and received most of my training from them. So I served on our Behavioral Health Advisory Board for 6 years and then on committees for about 3 years after that. And then the Alcohol Drug Advisory Board before that for several years. And I'm a person with lived experience in the criminal legal system and the behavioral health system. especially the substance use disorder, and I've been in long-term recovery. And I've been a long-time frustrated advocate too. And working with CalVoices has been really helpful. They provide, frank training and telling you what was legislated, and then we ask questions like, wait, that's not how things work. It actually works like this, and it's been a frustrating process. And so when we look to organizations like BHSOAC and CalBHBC, we need you as the BHSOAC, and we need CalBHBC to really look to the mental health boards more closely and support them more closely. This is it's the relationship between the mental health boards and their local BHS systems has become so friendly. There's almost no criticism and there's almost no pushback. And so the mental health boards typically will look to the BHS systems for guidance when we should be looking to the BHSOAC and the CalBHBC for guidance. We are supposed to be autonomous boards that are giving feedback to the supervisors that we collected and harvested from all the community through that CPP process. And we're filtering up the information to the Board of Supervisors. But what happens is things become very filtered before they get to the Board of Supervisors, and the Board of Supervisors simply look to the annual planning process, their typical budget and planning process as the end all. So I believe we have a great set of tools. There's organizations like CalVoices that could provide a lot of insight and help, and especially training county systems, like it was suggested by one of the commissioners, an idea I love. And I really believe that with more training, and just one final thing, mental health board participants are not required to get training. So when we go get trained and spend all our time getting training every year, and then we come back to our board to tell them what we're supposed to do, they just look at us, they don't agree or they don't understand the importance of all these elements. So one of the things that we could definitely do is ensure that mental health board members are all trained, and that may include just one last sentence, that may include virtual and video training opportunities for those that are just too busy. So thank you very much.
Thank you. And our last comment is from Kevin. He will need extended time. Your line is open.
So hello there. My name is Kevin Barnes. I'm a PhD. I'm sorry. Hold on one second. Hold on one second. Hold on one second. Okay. Wait. Elliot, are you going to be voicing?
Sorry, this is the interpreter. I wasn't aware that the speaker was signing, and I had to rearrange my apologies. Let me try to.
Is there a way that the other folks helping sign can let Kevin know that you guys need to restart?
And for our tech team, if you could spotlight Kevin's video rather than the black ASL interpreter screen. Thank you.
Okay. Kevin, do you see me? You see the interpreter now? Yeah. Sorry about that.
Are you guys ready to begin?
We're ready. All right, Kevin said, I see the interpreter now. So thank you, everybody, for your patience in working this whole thing out. I have 3 ideas that I'd like to put forward. The first one is adding a disability component and lifestyle medicine, and then also including getting more community members involved so that we can listen to some of the feedback from disabled people and get funding for the organizations that are following ADA rules and regulations in California to provide accommodations for disabled people as far as interpreting, to adding funding, and not on a volunteer basis, but dedicated funding for the disabled. The second thing would be, the state of Minnesota has a policy for all departments in the state. It's called C7C, that requires equality for people with disabilities in hiring. And that provides people an opportunity for CSDI and for the welfare system, bringing in people for work for 73% of people with disabilities. And the third thing is trauma-informed lifestyle medicine, which would be billable to Medicare. So I request that this commission work with Medicare to include lifestyle medicine in the healthcare system to provide preventative care to all disabilities. That would include mental health, physical care, and continuous improvement, as well as community coordination. And also propose dedicated funding for CPP advocacy in billing. And that concludes my comments. Thank you very much.
Thank you, Kevin. That was our last public comment.
Thank you, Mariani. And thank you again, Claire and Nicole, for your time and for sharing the incredible work that CalVoices is doing and for your partnership in this work together. There was, such robust conversation and so much more to build on in the work to come through our committees, through the commission's work as a whole. And I just have to say, so much of this conversation highlighted the importance of our Medi-Cal program. The Medi-Cal program does not exist without the Medicaid program at the national level and the funding. And in the spirit of uplifting these experiences and the importance of Medicaid and the importance of educating our elected officials, to the extent that you can reach out to your members of Congress to educate them about the importance of Medicaid, now is the time. Every corner of our state, 1 in 3 Californians depends on the Medi-Cal program, and we cannot underscore its importance enough. So this is the time to talk about that. Okay, thanks. Moving on, we are going to, thank you again. I'm so sorry, thank you. We're gonna do a little bit of a shift in the schedule again. We're gonna talk about committee placements, and then we will break for our executive session for a couple of hours, and then come back and take on the peer respite conversation. Very connected to this discussion, so appreciate your patience with that, particularly Commissioner Chambers. So moving on to the conversation around committee appointments. This is agenda item 7 in the packet of materials. For this agenda item, I have the honor of appointing members to the Budget and Fiscal Committee, the Program Committee, and the Legislative and External Affairs Advisory Committees.
Cody, move the slide.
Okay. Including the chair and vice chair positions for each. Our goal is to establish these today with the hope of commencing the meetings in June. The commission is also going to hear a brief update on the feedback we've received from members of the public of the Client and Family Leadership Committee and the Cultural and Linguistic Competency Committees. I want to begin this conversation by reminding us all, both our new commissioners, our longstanding commissioners, and the public, that this structure, the establishment of these committees, is a shift in the operations of this commission, and one that we hope will offer additional opportunities for transparency, discussion, and public input. The taking on of these new responsibilities through this structural shift is a new endeavor. So with that comes risk, but it also comes with opportunities for growth and reflection to ensure that the operations of this commission is meeting the intent of transparency, of communication, of building trust with our public. So we want to thank both our commissioners as well as our public for going on this learning journey with us as we seek to restructure the operations of the commission to better meet our mission. So appreciate that very much for you all. So I get to announce our appointments. Thank you. So for the Budget and Fiscal Advisory Committee, our chair will be our vice chair, Al Rolett. Thank you for serving. And our vice chair of that will be Commissioner Chris Contreras. Thank you. Commissioner Bunch, Commissioner Carnevale, Commissioner Gordon, and Commissioner Herabedian through his designee, Commissioner Pulmano, will be serving on the Budget Committee. The next committee is the Legislation and External Affairs Advisory Committee. Thank you, Commissioner Bontrager, for serving as our chair, as well as Commissioner Callan for serving as our vice chair, and to Commissioner Southard, Commissioner Mitchell, and Commissioner Larson for serving on that committee. And finally, for the Program Advisory Committee, I would like to thank Commissioner Tsai for serving as chair, and Commissioner Madrigal-Weiss for serving as vice chair, and Commissioners Baer, Commissioner Burnick, Commissioner Chambers, Commissioner Dave Cortese through his designee, Commissioner Schwartz, and Commissioner Cross for serving on the Program Advisory Committee. We will connect with the 4 new commissioners to see what you are interested in, ensure you have some context for each of the committees, and encourage you to attend these meetings. We recognize how busy your schedules are, but appreciate your commitment and leadership to this important work moving forward. I feel like a round of applause is in order. Moving on to our existing public committees. Again, this is the Cultural and Linguistic Competency Committee, as well as the Client and Family Leadership Committee. You all, as members of the public, as well as the commission, received a survey to better understand what is the interest in these committees, what should the focus be, how do we ensure they are meaningful uses of time and opportunities for engagement with the public. And we've received incredibly helpful feedback about how these committees could continue to evolve. To discuss these comments and gather more, we are planning to host a public convening. Commissioners Chambers, Callan, Burnick, and Southard have expressed interest in working with the public committee, so we look forward to that participation. So again, as we think about how best to utilize the committee structure, particularly with members of the public, we want to continue to collect some information about that. So stay tuned for more about that public listening session that we will host, including inviting existing members of those committees and past members of the committees, as well as members of the general public. At this time, I would like to invite commissioners to offer comments or reflections on the work ahead or ask any questions. Please.
Thank you. Thank you for your leadership. I look forward to
the new possibilities. I did have a question relative to your last statement. Can you, like, just, because I know you're very smart, can you laymanly tell me what that means, the last part? Like, what, I mean, I know that there was the survey, there's going to be a public session, because I've just gotten emails from the public and people concerned, and I know you're going to be facilitating a conversation, but like, what does that mean? Because people say that all the time, and
Yeah.
like, what does that mean?
I appreciate the clarity. So I think what it means is that we want to have a public opportunity, an open conversation about the purpose of the CFLCC, and the CLCC, in order to ensure that we're all on the same page about what we want to get out of that time together. I think over the last few years that we've served on these committees, there's been some frustration about what was the point of that? Where we have opportunity for input? What sort of decisions can the public weigh in on? Those are some key questions that we want answered before we start convening this group. We don't want to waste people's time, both commissioners and members of the public, but at the same time, we want to utilize this structure to meaningfully collect information from the public. So what does that mean? What does that look like? And to have those conversations. Many members of the public have been part of this commission for years, longer than any of us, and have reflections on what happened before, what could be more effective moving forward. So let's put that on the table. We've made the decision that our advisory committees, the 3, will not have members of the public. So if we're gonna have committees that have members of the public, why? What is the purpose? How can we ensure that we are, again, meaningfully collecting that data? So this public session will offer opportunities for that, and then we'll come up with those recommendations and present them to the commission and the public to make that decision moving forward. Does that help?
Yeah, and this is great. Do we have anybody that has any knowledge, and I could ask Commissioner Tamplin, but like wins, like from these committees, like, cause I know a lot of the peer respite work that's coming to fruition now was on the back of other people and Commissioner Tamplin and the work that they did for 14 plus years. So I'm like, I want also the public, and I wouldn't have known that if people weren't mentoring me, to know like the power of what these committees have done. And now it's going to be in the CalAIM, right? That's a huge, like the peer respite, a lot of that work came from this commission, and now it's going to be integrated into managed care plan. So I know that's the public's feedback too. So I just want to see if there's any way, if there's like a one sheet or a half sheeter that can be like, what were the wins in the last, 10, 15 years of these committees, and like what the power, because like that's pretty huge.
I so appreciate that, Commissioner Chambers. And actually last year, we asked the same thing of Tom and team to pull together what are the wins of the CLCC? Where has the committee weighed in on the commission's decision? So I actually think that is a very logical next step and some good background information to have in advance of that public conversation. Do you agree, Will? Okay, great. So yeah, absolutely. Thank you for that. And again, thank you for the public's interest and the commission's interest in moving forward this important conversation that incorporates community voice. Any other comments or questions from our commissioners? Okay, Mariani, if you could go ahead with public comment, please.
We currently have one in-person public comment from Stacy.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Good, yeah, we want to see you, especially the new commissioners. Welcome to the new commissioners. I talk a lot, so I tried not to, but I really had to weigh in on this. I do want to thank the commission, the chair and the commission, and I do not mind you taking your time on this because it is a big change. And I think I have expressed, on behalf of REMCO, the Racial and Ethnic Mental Health Disparities Coalition, that we are concerned because the OAC the commission has had a very good tradition of having members of the public on the committee along with the commissioners. Now, I know you, since you have so many more commissioners, I'm willing to give this a chance because I know, Commissioner Alvarez, you do want to hear the public and stakeholders. So I'm willing to wait and take a chance and, you know, let's see how this works with only commissioners on the committees. I'm very concerned again that one of the things that was able to take place on the committees was dialogue, not just this us coming at the end making a 3-minute or less statement and then not getting any feedback or interaction with the members that sometimes had questions and we couldn't even answer them. So if that's going to happen at the committees, I'm worried about that. But again, I'm willing to, you know, take a chance and let's see what happens. And I do want to say that the commission also should be very proud of yourselves because your bylaws, you're going to have to change your bylaws because the bylaws say that there should be on every committee at least 2 consumers, 2 family members, and 2 members of the public that know, I'm sorry, I can't remember if, it is about diversity, racial equity, and those kinds of things. So you've had a great tradition, and you're going to break with that. But again, I'm going to, you know, advise my colleagues, let's wait and see what happens, because again, things are different. You have a bigger membership, and I want all the commissioners, of course, to be active committee members. So anyway, thank you so much.
Thank you, Stacy. That was our last public comment. We don't have any virtual comments.
Thank you, Amariani. And thank you again to this commission for stepping up and joining these committees. Again, to Stacy's comment, which I'm not supposed to comment on, I mean, just in general.
So sorry, at the very last second, Mark raised his hand right as I said there was no virtual comment. Should we take the comment?
Okay, go for it.
Yeah, okay. Go ahead, Mark, your line is open.
He went away.
Never mind.
Okay.
Oh, thank you very much. This is Mark Comments. I want to back up what Rachel Chambers was saying about getting people included and having an empowerment. She was right on the point. And also Project Return Peer Support Network is also doing the training on the certified peer specialists. I don't have the next update yet, but I'm going to try to get that, and I usually spread it county-wide, that information. So it's very important that the certified peer specialist trainings take place, that they are, and that we are included on all committees. Our Department of Mental Health now has what's underserved cultural committees. Now, I don't usually go to those meetings, but we need people on those as well. Okay, so I want to urge people to be there. Thank you. And I would like to give you the phone number for the community planning team meeting that will take place tomorrow. That's on Microsoft Teams. And I'll try to do that at the end of the meeting. Thank you.
Thank you, Mark.
Thank you, Mark. That was our last comment.
Thank you. Again, deep appreciation for everyone's commitment and patience as we go through this process together. Looking forward to learning and looking forward to being effective in our work ahead together. With that, I am going to break us for our executive session. Again, the next couple of hours will be dedicated to entering closed session for the consideration of a personnel matter per Government Code Sections 11-126A. We will return at 1:30 to reestablish quorum and report out from the closed session. If closed session runs longer than anticipated, we will provide an update at 1:30 p.m. Commissioners, please grab your lunches first in the front conference room before walking over to closed session. Thank you.
Okay, commissioners, it's 1:30. I'm requesting everybody take their seats. We're going to reconvene to reestablish quorum in the public. Commissioners, asking everybody to take your seat. Thank you. If you can hear me, clap once. If you can hear me, clap twice. Thank you. Please, commissioners, take your seats. We need to get started again. Thank you. All right, folks, we're reconvening. Oh, she goes because she has to.
Welcome back. Hello, everyone, and welcome back. I hope you enjoyed your lunch. Okay, first I'm going to ask I have a second career. First, I will ask Sandra to please reestablish quorum with the commissioner roll call.
Thank you. Commissioner Bear. And I'm asking all commissioners joining us virtually to please unmute your line so that you're ready to come back. Commissioner Bear. Commissioner Burnick. Commissioner Bontrager.
Here.
Commissioner Brown. Commissioner Bunch.
Here.
Commissioner Callan.
Here.
Commissioner Carnevale.
Here.
Commissioner Chambers.
Here.
Commissioner Contreras.
Here.
Commissioner Designee Swartz. Commissioner Cross.
Here.
Commissioner Fairweather.
Here.
Commissioner Fernandez.
Here.
Commissioner Gordon.
Here.
Commissioner Designee Pulmano. Commissioner Larson. Commissioner Madrigal Weiss.
Here.
Commissioner Mitchell. Commissioner Robinson. Commissioner Southard.
Here.
Commissioner Sy. Commissioner Wilkes. Commissioner Vice Chair Roulette. Chair Alvarez.
Here.
We're one short from quorum. We need, we need Sy. Okay. Huh? No, if I can get him to come back in. We're just for the public, we have 13 in the room. We need 14 to establish quorum to restart the meeting. So we are waiting for Commissioner. That is another commissioner to just join in. And I am seeing Commissioner Sy walk in and we'll be taking a seat. And as soon as he takes a seat, we can continue. Thank you, Commissioner Sy. I'm recognizing you for the meeting. And we have quorum.
Thank you, Sandra. I will now report back on the closed session. The commission voted to offer the executive director role to a candidate. The identity of the candidate shall remain confidential pending acceptance and passing background and reference checks. I want to express my sincere appreciation to the 9 commissioners who devoted many hours to participating in the executive director screening committee. I especially want to appreciate the leadership of Commissioner Robinson as chair of the committee. Thanks to the dedication of this group, we are now well positioned as a commission to move forward with confidence in the next phase of our leadership. And we look forward to reporting back to the public. Thank you so much. We are now going to move on to agenda item 11 around the peer respite concept paper. The commission is going to receive an introductory presentation on the upcoming $20 million investment from the Mental Health Wellness Act grant focused on peer respite. Just want to express appreciation to the leadership of Commissioner Chambers for her partnership with the team on this important work. As a reminder, California's Mental Health Wellness Act, the grant program provides $20 million each year to improve community response to people facing behavioral health crises. These grants have supported the ability of crisis responders to reconnect those having a behavioral health episode with wellness, resiliency, and recovery-oriented programs that offer the least restrictive settings appropriate for their needs. In September of 2022, the Commission directed staff to focus on 5 priorities for funding of the Mental Health Wellness Act, of which one was peer respite. The Commissioner's Peer Respite Project, led by Commissioner Rachel Chambers, will explore opportunities for investing these one-time funds in peer respite. In addition, this project will also support a broader discussion around peer services that, as we reflected on earlier today, is a robust topic of interest across the Commission and across the public. I now invite Dr. Melissa Martin-Mullard, Chief of Research and Evaluation for the Commission.
Thank you, Madam Chair. And I am standing in for Dr. Kylie Mason, who couldn't be at the meeting today. So I'm going to just provide us with some grounding in peer respite along the peer services continuum. But really my role here is to just provide some space to generate discussion and to update you on where we're at in this process. So I'm going to skip to this slide. So just so that we're all operating from some common language, peer respites are voluntary, short-term programs, usually overnight, that provides community-based, non-clinical support to individuals experiencing or at risk of experiencing a behavioral health crisis. Peer respites are staffed and operated by people with lived experience of behavioral health issues. They're really rooted in the foundation and principles of peer services. We've done a preliminary examination of the literature and find that peer respites strengthen self-reliance and social connectedness and may help lower costs due to diversion from EDs, as well as hospitalizations, psychiatric hospitalizations. Current estimates are that there are about 10 to 12 peer respites operating in California. Those numbers may have fluctuated since data were published, but based on our initial investigations, that's the number of peer respites throughout the state. And they've been funded primarily through a variety of public and private sources, including MHSA dollars. So as Chair Alvarez mentioned, this project is led by Commissioner Chambers. And we are really kind of at the start of our staff investigation and work on this project. But so far, we have been able to do a site visit to the Share Recovery Retreat last month. And are working on scheduling with Sally's Place in Alameda, Insight Peer Respite in Grass Valley, and Second Story in Santa Cruz. Part of this effort also includes doing a literature review and landscape analysis and key informant interviews and focus groups with individuals who will be able to share their insights and subject matter expertise on these programs. So some of the initial key areas that we are planning to explore include this list. So what is the current policy and funding landscape? We have a preliminary sense of how current peer respites are funded, but we want to dig in more and kind of match some of the current initiatives and opportunities to that funding landscape or those funding possibilities. We also understand that peer respites fall within the crisis continuum, but we want to better understand just where along that continuum this can be a helpful resource for individuals. We want to understand the processes and requirements for establishing a peer respite, understanding that there are going to be potentially differences depending on the county that they're operating in, or depending on the agreements with county behavioral health and others with local county environments. We want to examine the level of diversity among peer respite operators. So really looking through an equity lens to try to understand that current landscape. We want to identify best practices for peer respites that are operating so that we can look to elevate those best practices for any that are in early implementation stages. To look at the connection between peer respites, behavioral health, and housing services. At the SHARE peer respite we visited, we learned a lot about the ways in which that program links participants, individuals into housing. So we want to connect those dots. Cost, funding, and sustainability of peer respites, and then what technical assistance needs are required or needed or wanted to support the success of current as well as future peer respites. So again, to recap the opportunity, we have the Commission has set aside $20 million over 3 years of Mental Health Wellness Act funds for a project centered around peer respite. So again, we're kind of at the initial stages of launching this project, and we'll be working in the next phases to seek your and the public's guidance on the project to help us narrow down and kind of flesh out the opportunities and priorities. Here's kind of just a general timeline, so you know where we're at now is, again, these initial site visits, focus groups, discussions with key informants and subject matter experts across the state. We're kind of launching this project to you and the public today. In July, we will come back and have a public hearing where we'll be able to have others up here kind of speaking to the value and promise of peer respites. And that is when we will also present a more detailed project plan that incorporates the feedback and information that we've gathered from now until that time in the summer. In October, November, we will summarize and produce a more robust project policy paper or plan that builds off of the initial document that you received in your packet today, but contains more detailed information and a more structured plan. And then in November and December, we will draft the RFA for this opportunity, and at the January Commission meeting, we'll present findings from the project and the proposal for peer respite. So that's kind of from now through next January how we're sequencing our activities. So with that, I will turn it back over to you, Madam Chair, and welcome any questions. And don't know, Commissioner Chambers, if you want to add to anything.
Yes, Commissioner Chambers, any comments?
Yeah, I just want to get the room excited. I mean, I don't know if, I know it's like after lunch, but like what was presented is actually, as a behavioral health practitioner, is probably one of the most exciting provisions of service, and I believe ways to divert people from psychiatric hospitals and settings that would make you worse. I think like starting off this conversation is like really putting yourself in the position of someone maybe going through your first psychiatric crisis, like myself, or maybe one of your daughters or parents or family members, and maybe not having anywhere other than to go to a hospital where people with maybe not the same level of acuity as you, and you actually get worse. And that has been my experience. There's been times where I've been appropriately hospitalized, and there's been times where there was no need for me to take myself to a hospital and get worse. And so I think that if you can imagine with us a system where we don't, emergency rooms, law enforcement, behavioral practitioners can have a menu of transformative, home-like wellness and type environments to send people struggling, including maybe yourself one day, to a home-like environment where you can leave in 2-3 weeks with wellness tools, like taking action for your wellness RAP training. So you'll have wellness tools. You might get a psychiatric advance directive, learn how to advocate for yourself for the next time you go into a crisis. And you leave with not a warm handoff, a hot handoff to linkages and support so that you don't go back to the emergency room and end up back there. Imagine the system. And I think that that's how we preface this conversation. And I think that the things I'm excited about the commission as we are with CalAIM, BH Connect, and the new ECM and community support benefits, and I know we'll explore that more, but DHCS did announce on our peer call and amongst other folks that they are, I don't want to speak for them, but they are approving the transitional housing resources under the managed care benefits to be able to support these. So while the counties, were pioneer in being able to use MHSA money to fund this, and private folks, rich people that want to give their homes away to support this, I think there's an opportunity with Prop 1 and with BH Connect to be able to utilize and hold managed care, commercial plans as partners to be able to fund these alternatives to hospitalization. So if you all can imagine with me and partner with me and the team to be able to find holistic tools and strategies to provide people with, places to go outside of a hospitalization, and places when they leave, they can be empowered and come back and heal in community. And that's all I'll say, but I do look forward to the billing aspect and the guidance and the technical assistance and ways in which we can braid funding and resources so that this is sustainable for peer-run, operated organizations, not large corporations, to come and co-opt the peers, which is like what's happening. But we can be sharing, but the peer-run organizations are the ones that have really been able to embody these models, and I hope that we can be thought partners to corporations on how to do this, but we be the leaders and teachers, and then they can learn from us. And if they want to do it themselves, they do it off that. And I will save more of my comments, but I really want y'all to imagine this is probably one of the most, for me as a practitioner, transformative solutions, and it's going to be a workforce builder as well. Thank you.
Thank you, Commissioner Chambers. Vice Chair Rolette and Commissioner Carnevale.
So my disclaimer is that for 20 years, I was associated with Insight Respite in Nevada, in my role at Turning Point as the Chief Executive Officer. So do I believe in peer respite? Absolutely, for all the reasons Commissioner Chambers just said. And so when you go and visit, I ask you to consider some of these questions, okay? So first of all, peer respite in terms of funding has a range of different funding mixes, and some peer respite programs are actually billing Medicaid, reducing the dependence on MHSA funding or other county funding, which oftentimes waxes and wanes given the budget cycle and what's happening in the economy. But if you can bill Medicaid, again, there are lots of things that are happening nationally that might jeopardize that. It sets you apart. So find out which of those programs are able to do that. And then what are the unique challenges associated with sustainability about that? And then what are the attributes that have resulted in an organization or a program being able to bill Medicaid? Is it the relationship with the county? Is it a relationship that the workforce has with the managed care organizations? There are factors there that make peer respite different. You want to understand that. you also want to ask for the individuals that are served in peer respite that oftentimes are experiencing an acute psychiatric crisis, and forgive me, I couldn't think of a way to say that better. That's my post-lunch vocabulary being a little bit limited. But when they transition away from peer respite, many of them utilize managed care services for ECM and CS. How effective is that? Are they able to engage effectively? And then find out what recidivism rates are in peer respite. You want to know what the recidivism, and if they don't track recidivism, in my opinion, it's a red flag. You should think about that, because we should be tracking recidivism. And those are things that in your report, when you come back, in your visits, you want to talk about where some of the differences are. And then lastly, how many peer respite programs have private funding? And again, I just think that in this unique time that we're in, the sustainability of the peer respite efforts requires a blending of funding streams, and even things as simple as, do you own the facility that your services are being provided in? Who owns and operates the facility? Is it a lease? Is it your property? All of those questions really do determine, have a lot to do with whether or not peer respite can be effective. And then I thought this is my last point, I promise. Workforce, the composition of your workforce in peer respite. And then truly, is the person who is running the program a member of the executive leadership team? And do they influence the trajectory of decision-making, or are they essentially have a subordinate role, and they don't have executive leadership access or influence? And that, again, is an important feature. Some peer respites are peer respite in name only, and that the individuals who are running the program do not get access to executive leadership. And in fact, they should be a part of the executive leadership team, as far as I'm concerned.
No strong opinions there. Thank you, Commissioner Rolette, or Vice Chair Rolette.
Thank you.
We're going to move on to Commissioner Carnevale and then Commissioner Wilks. And this is not a reflection of Vice Chair Rolette's, but if folks can try to keep your comments brief, we may actually make it through our agenda.
I don't know. I always enjoy listening to our Vice Chair wax eloquently about things he knows a lot about.
Well, see, I represent CBOs, and this is our thing.
It's your world.
And peer respite. I'm waxing eloquently.
Go.
What you said is true. Peer respite is a cost-effective alternative of care, and it works. Why does it work? And we, as a commission, have an opportunity to really advance that. And the people with lived experience understand and recognize distress and difficulty far sooner and quicker sometimes than trained professionals like myself. And I learn a lot from listening to Commissioner Chambers and other people with lived experience talk about that unique sensitivity. It makes me a better practitioner, a better deliverer of service.
Thank you, Madam Chair. I would like to add to that. I think the way I get excited about this and the way we get others excited about it is not only that, but to elevate it above that level. So when I said earlier today about writing a report, I think this is an excellent construct to look at peer respite. But what I'd like to do is I'd like to see it elevated at a level above that, so we can talk to the governor and to the legislature, not just about peer respite and why it's good, but why it's strategically important to the state. And in order to get to that level and to this commission, you have to look at it in the context of our strategic plan and understand how it impacts prevention and early intervention and data and all the other elements, and bring into other considerations. There's one new commissioner who's really interested in how do we elevate people with lived experience to actually become effective workers in peer respite. So there's a lot of elements here that we can make more strategic and be saying to the state, here is why we have to lean into this in a big way, and I'd like the commission to do that. So I'm making that as a statement, but I'm also directing it to Dr. Martin Millard and say, can you imagine, I don't want to turn this into a year-long project, but I'd like to find ways to elevate this in the context of the report you already have, and let's consider some of those other elements. Let's also bring in the work that we've been working on with the sustainable financing and bring some of those elements in, and let's imagine how could we create a really effective system that's not operating with scarcity, but it's operating with abundance, so that when we're making this argument to the state, we're asking for the money it takes to do it the right way, but to show that we actually can save money by doing it the right way for the state. So that's what I had in mind here. Thank you.
Thank you. Commissioner Wilks and then Commissioner Bontrager.
All right, Chair, I got you on the timing. So, so 3 points here. Ben, personally, as a youth, had experience with respite, professionally working in that environment, and then also advocating for these services to be available here in Sacramento, specifically, as Commissioner Chambers said, about even myself. There could be a point in my time in the future where I need a resource like this. And so the question is, what are you doing about youth? And I bring that up, one, because it'd be nice to get part of that funding to support what is going to be the best practices. They have youth homelessness prevention centers right now. I know about that, lived experience myself, but also faith communities and the properties that they have available to actually support the sustainability of such programs and the facilities needed there. Good?
Wonderful. Thank you, Commissioner Wilks. Commissioner Bontrager and then Commissioner Fernandez.
No, that's very good. I think you can add a little more muscle too. When you look at the issue of inappropriately boarding individuals in emergency rooms, as a health plan is a concern for us, obviously, but I meet with the California Hospital Association every month, and this is the #1 topic that we speak about every month, is the inappropriate boarding of folks in emergency rooms. If this is a diversion to that, where folks can get better help more appropriately, more timely, with less cost to the system, this is a win all the way around. So I would invite you to include CHAW in this conversation. That might add a little more political muscle to it.
Thank you. Commissioner Fernandez, please.
Thank you, Chair. I'm excited to see that peer respite programs and more peer-run organizations and recovery community organizations are beginning to take a center stage again, especially as we move into more value-based models of care and recognize the importance of population health management. On a national level, as I've heard of more RCOs in states like Colorado that have implemented peer programs, it seems as though the almighty dollar always causes people to turn their heads to Medicaid funding. And by and large, what I've heard over and over again, that the secret sauce of peer respite programs is lost, and the value that's associated with peer respite programs is diminished because of the fact that they have to adhere to bureaucratic and administrative processes that are associated with Medicaid. Moreover, in the state of California, I'm aware of a number of peer respite programs that have tried to figure out, how do I actually employ some of my peers as Medi-Cal peer support specialists? And they run into the problem that, oh, do I have to become a certified outpatient provider? And what does that mean in terms of employing all of the overhead that's associated with that, when all I really want to do is employ peers? And so I would caution that we move carefully as we move forward, leaning into Medi-Cal as a primary payer of peer respite services, because my fear is that peers will then very quickly be driven out of the peer respite programs, and it'll lean into a practitioner model of care.
Thank you, Commissioner Fernandez. Very connected to our earlier conversation as well. Any other questions from commissioners before we open it up for public comment? Great, thank you. Amariani, please. Oh, just. No, I don't think so. No, isn't that next? Oh, just kidding.
Oh, we have-
Commissioner Southard.
I just wanted to talk about one of the models for peer providers that Brenda may be able to help us a great deal with in the future is that a prison in which I do volunteer work has a peer training program for peers with co-occurring disorders, so that upon release they become providers of peer services, and the model has been very successful. And sometimes it can be done in such a way that it's Medi-Cal billable, others not, but the model is extraordinarily successful.
Thank you, Commissioner. Okay, I think we're good. Amariani, please.
Okay, we currently have 2 in-room comments. The first one is from Richard. Your line is open.
Good afternoon, Commissioners. This is Richard Geller from Santa Cruz County. What I want to make a point that needs to be part of the application process where any respite programs, that they need to have 2 wheelchair accessible units. We need to increase the number of dual diagnoses of individuals with disabilities so that they have equal access to a respite program. That is critical. No one should be turned away because that particular facility isn't accessible or do not have a wheelchair accessible room. Secondly, there is funding sources to tap on with Proposition 1 with the housing bucket in more than one categories. But the question is that going to be sustainable for the operator, the rest of the program, to be able to pay their staff overhead costs, feeding of the clients, transporting, etc.? That may be the only financial issue or barrier faced. The other thing is any counties that have respite program, I truly believe that the state should allow those operators to bill Medi-Cal directly and do not need permission from the county, whether you will or will not be billable. Because the county is more than likely will say no because they don't want to have part of the staff to do helping with the billing issue with the provider, because that's going to take staff time to do that. Unfortunately, it's a reality. It's part of their job to do that as a county and helping the operator, but we need to allow them to be able to do it in order to increase the number of available hours that the state is utilizing and then gradually increase over time as the system gets fixed while dealing with the barriers of the billing system in itself. So that's one of the things you need to keep in mind. The other thing is I think you need to look at the language issue of the service provider in providing respite. Are they going to provide adequate languages in that community? Spanish, Chinese, Russian, American Sign Language for a deaf or hard of hearing individual? That's really critical in the issue of accessibility to those programs and services. Otherwise, I can turn around and file a complaint with the California Civil Rights Office because that particular respite program refused to provide me a sign language interpreter or have staff that are competent and certified in providing those services while I'm seeking my treatment, because I am hard of hearing myself. So you need to be aware of all the legality issues that needs to be resolved, sorted out into consideration as a whole package. Thank you.
Thank you, Richard. Our next comment is from Mark Karmetz. Your line is open.
Hi, this is Mark Carman. So basically, I want to tell you that we just found out that Project Return Peer Support Network is opening a new peer respite program. Close to the University of Southern California. And this, in my view, is something that we need to do. The comments that Richard just made with regards to accessibility, I want to thank him for doing that, because we need to start to get that going. That's important. And for people who are able to walk, that's not upfront for us. Whereas people who are not able to walk and are having trouble hearing and seeing and whatever, that's right in front of them. That's right there. So we need to make sure that accessibility is there. And most buildings that I go to now do have them, ramps and stuff like that available. But there are still some that don't. Accessible bathrooms, accessible, everything that is needed for them, that needs to be there. And I agree with Richard on that one. So basically, I just made an announcement that Project Return is opening up a new peer respite program, and it's going to be by University of Southern California. So I want to let CalVoices know that that's taking place, and all the other people on the board. So please, thank you very much, and that's mine.
Thank you, Mark, for your comment. Our next comment is from Azrule. Your line is open.
Good afternoon. Yes, I'm so sorry. I thought I was on mute. Good afternoon. This is Dr. Israrullah Mohammed, licensed clinical psychologist, systems equity strategist, and the author of the Bureau Care to Custody Cemetery Pipeline, the public health framework developed through a decade of lived experience, systems analysis, and direct services across Los Angeles County's behavioral health. Excuse me. Commissioner Fernandez's and also Commissioner Chambers' recent acknowledgement of two critical issues: the harmful impact of bureaucratic complexity on care access, and also the urgent need for workforce equity and structural realignment. These are not abstract concepts, they're embedded in my model, which was submitted into public record during the April 10 the Behavioral Health Commission meeting, and it addresses exactly how fragmentation, oversight breakdowns, and professional exclusion deepen community harm. Unfortunately, while portions of this model have been quietly implemented across MHSA planning, the Anti-Racism, Inclusion, Solidarity, and Empowerment division, and then also Contract Management and Monitoring division, as well as Quality Assurance, they have been applied without author engagement, fidelity, or structural accountability. When frameworks designed to protect public health are absorbed without equity, the result is not reform. It's replication under new branding. I respectfully ask the Commission to consider, are we building systems that prevent harm or reproducing the very inequities we claim to dismantle? Equity is not procedural, it's structural, and it must be practiced, not just performed. I remain available to contribute this work with transparency and integrity. Thank you very much.
Thank you. That was our last public comment.
Thank you so much. At this point, that was an informational item. So thank you so much, Dr. Martin Mollard. Okay, we have about 50 minutes left in our agenda and 3 prominent items. I'm going to look to you, Will, for your guidance and if we think we can get through these, or do we want to do some shuffling?
I think we have to just press forward and go very fast. So that means a lot of self-control.
Okay, I'm going to allocate about 20 minutes for this item. Please, Director Zoller. Agenda item 8, Kendra Zoller, our Deputy Director of Legislative and External Affairs, is going to provide a brief overview of legislative priorities for the Commission to consider supporting. The 6 bills are robust. I will hand it over to her.
Okay, thank you very much. I will start with the bill that we basically already supported individually last month. As you'll remember, we supported it last year. I'm bringing it back for the official vote. This is the one Commissioner Brown brought up about creating a do not sell list so people can voluntarily add themselves to this regarding firearms. So this is just procedural. So I think we can go quick on that one. AB 96 by Assemblymember Jackson, sponsored by CalVoices. It would allow peer support specialists to qualify as community health workers without needing additional education, training, and certification. CalVoices has proposed an amendment to further narrow this provision, limiting it to qualification as community health workers specifically for behavioral health services. Community health workers can bill for preventative services under managed care plans, and their role is being further expanded under CalAIM. As you heard this morning, peer support specialists are limited to specialty mental health. This bill is helping to advance the conversation around the potential overlap between the scopes of these 2 roles and highlights the reality that the state lacks sufficient numbers of either to meet the population needs. The author has decided to make this a 2-year bill to allow for more time for conversations to be had among stakeholders and work through the complexities of this bill. So I want to change my recommendation today to be that the Commission directs staff to participate in those conversations and provide regular updates through our newly established Legislative and External Affairs Committee. The Commission has previously expressed support, including earlier today, for integrating peers into more settings as a part of the strategy to address workforce shortages, and that's what this bill aligns with. I'm going to go all the way through, and then we can discuss. Moving on to AB 348 by Assemblymember Krell. This bill addresses inconsistent eligibility requirements for full-service partnerships, which often prevents individuals from receiving care. You heard about FSP eligibility hurdles last month when our FSP report was presented, and it includes a recommendation for clearer eligibility requirements to reduce wait times and improve service alignment. So this is what this bill is trying to address. The presumptive eligibility requirements is backed by data developed by the Steinberg Institute. This bill also states that a county would not be required to enroll an individual who meets this criteria if doing so would exceed the county's FSP funding through the BHSA. There are some amendments coming from Tuesday that are somewhat technical. CBHDA does have an opposed LS amended position, but I don't know what their position is on the amendments that are coming out. They're requesting amendments to align presumptive eligibility with the current BHSA requirements, which I think some of the amendments will address. The bill will be heard next week in Assembly Health. And then AB 1037 by Assemblymember El-Hawari. This bill modernizes outdated laws to support evidence-based, compassionate substance use care. It expands access to Narcan, eliminates abstinence-only treatment requirements, and supports medication-assisted treatment, which aligns with the Commission's existing Mental Health Wellness Act grant. The bill aligns statutes with the overarching policies of California around SUD treatment, recently enacted laws, and best practices throughout an individual's recovery journey. There's broad support, except the El Dorado County DA and Sheriff oppose it, fearing it promotes harm reduction too far. But the controversial language mostly has been removed, and as the sponsor notes, just say no doesn't work for everyone. SB 531 Rubio. This builds on the Commission's previously sponsored mental health education bill, SB 224. That bill required mental health instruction for middle and high schoolers in schools where health classes already exist. SB 531 expands that to ensure all students receive age-appropriate mental health education. All of these components are described in the law. The students and staff who are already receiving mental health education as implemented by SB 224 have reported positive feedback. The commission has a strong policy record supporting this work, and the bill has broad support. It'll be heard next week in the Senate Education Committee. And this is an easy one. It's just a technical omnibus bill. I included language in here that cleans up anywhere Prop 1 missed changing our name, so it's nice to support it since they added that for us. And lastly, there's a handout on Bagley-Keene and Political Reform Act in your packet. All of you are leaders in this space, so you might have affiliations with the organizations that could have positions on these, so you can use that to determine if you need to announce your affiliation or recuse yourself. Happy to answer any questions.
Thank you, Kendra. I can begin that process and let you all know that my organization is a sponsor of SB 531, Mental Health Education in Schools. Yay. Okay, any comments from commissioners, please?
I'll be quick. Giving me that look. Okay, so I want to just put it out for the record. The purpose of AB 96, in our opinion, as peer leaders, strategically is to integrate peer support workforce into the managed care plans. We are right now only in specialty mental health. It makes sense that we be able to serve the full continuum of acuity of our residents in California. I found opportunity and a little concerned when I talked to the sponsors of the bill that potentially that there was some behavioral health associations of directors and other advocacy organizations that put opposition to the legislation. As it's noted, people like Painted Brain and CalVoices will be implementing enhanced care management, community health worker benefit, and community supports. We do not understand why we are not allowed to operate in managed care plans. And this bill was a step into getting that way. And then, yeah, I know it's being expanded to a 2-year bill, but I just found really great distress and confusion as to why there was immense opposition when we as individuals with disability, with lived experience, deserve this right, and we don't believe nothing about us without us. So I'm excited to be able to work at the table for the next year with CalVoices and any other associations, behavioral health directors, any racial ethnic organizations, to be able to bridge a partnership with the community health worker workforce and any other directors that find opposition to peers moving into commercial spaces, because we already are there. We are already doing the work. Why not recognize us as people that don't want to be on disability? We want to work. We want to be able to prove that we can provide the continuum of care just like any other profession, and that the managed care plans deserve to know our workforce. And I think that's all I'll say. But I want to work with people, but it just was a little distressing to hear that. And I want to put that on the record, that CalVoices wants to work with people and will do and have amendments. And I want to thank Dr. Corey Jackson for his leadership and believing in our workforce, that we have the right to be able to serve Californians. And I hope anybody else that's trying to oppose it can give us a reason why we should not be operating. Thank you.
Thank you. Other comments?
Yes, just for clarification, Commissioner Chambers, who specifically is opposing?
There's no official opposition, so I don't want to speak for those that don't have a official position, but there were some issues raised by CPEN and I believe CBHDA was part of the conversations, but no official position.
Thank you.
I think what I have heard in the community has been that there is a broader conversation around how are we supporting community workforce more broadly, whether that's peers, community health workers, promotoras, doulas, there is this big movement by our Medi-Cal team to integrate this workforce, but it's haphazard. There isn't a real strategy, there isn't consideration for how that workforce should be paid, how much, the quantity at which you're billing these services, and they're lumping everything and trying to move things in a patchwork way. So I think there's some interest in ensuring that there's like a more strategic conversation around that. I definitely think that there is a general sharing of commitment to uplifting peers as community leaders in having that workforce component, but I think that's some of the questions that want to get ironed out.
So is it because they want to be more inclusive?
Advocates, yes.
Thank you.
Great, okay. So there is a motion per legislation. No, just kidding. Oh, okay. Public comment, Mariani.
Okay, great. So our first public comment is from Richard. Your line is open.
Hello, Commissioners. I would like to appreciate Commissioner Chambers and her comments and feedback. It's shameful, it's disgrace, and it's not surprising that the Association of Behavioral Health Directors are not standing with us, because it just shows that they do not value us as peer workers. Plain and simple. We don't have the buy-in from them, we don't have the trust from them, and we don't want to take part of the funding away that they use for their regular workforce that doesn't include peers at the county level. So let's be loud and clear. We need to continue to push it and stand by and tell the state agencies, the Department of Healthcare Services, Department of Health and Human Services, stand with us, not against us. Remember, with Proposition 1, peers was never included, or CalAIM or Proposition 1. We were totally excluded. And the commissioner back then backed them with a letter of support, with reservation, but yet you allowed it. So we need to fight the fight. I am willing to go to Sacramento and raise hell. Thank you, Chambers, for mentioning it. We need to stand up to those directors who don't have trust in us, who don't have support in us. Shame on them.
Thank you, Richard.
For the remaining public comments, if you are supporting any of these bills, if you could be brief, if you are responding to some comments of commissioners, I would also encourage you to be brief. Thank you.
And then, Chair, we actually did have an in-room comment from Stacy. If you go ahead, Stacy.
Good afternoon, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. REMCO did not take a position on this bill, and we are most willing to work with the sponsors because REMCO totally supports that peers, certified peers, should be able to work in Medi-Cal managed care and receive reimbursement for their services with mild to moderate. We totally believe in that. What this bill did, though, was to equate two professions that, while are similar, have very basic differences. And that is that of the community health workers and peer providers. Yes, there is overlap. Yes, some of their work is overlap, but they have very different histories and very different origins, and in some instances, different values and priorities. So that is why we felt torn, because while we totally support peers, again, in getting reimbursed, I think it's important because I know, I won't speak for other organizations, but that is why REMCO was not able to support this bill. So I just wanted to make that clear. And then I did want to mention, there is a new, this is totally different. I do support the other bills that you support and want to thank the Children's Partnership for sponsoring 531. But I did want to mention AB 1242 by Assemblymember Nguyen. This is a priority bill of a new coalition of Asian health providers and health advocates around the state. It's the California Asian American and Native Hawaiian Pacific Islander Health Equity Coalition. I'm proud to be a part of this coalition, but this is their priority bill, and this addresses the systemic and widening disparity in access to services in California by ensuring individuals with limited English proficiency and individuals who are deaf and hard of hearing have meaningful access to health and human services. So again, in the interest of time, I won't go into this, but I just hope that the Commission considers bills like this. It may not be a priority bill, but again, in order to receive culturally competent mental health services, if you don't speak English, if you want to receive services of any kind, you really need language access. Laws have been on the books for many, many years, but you know, there are ways around it or they don't get enforced. So anyway, just consider that, and thank you again.
Thank you, Stacy. Our next in-room comment is from Maron. Your line, you can go ahead.
Hello, nice to meet you all. My name is Meron. I'm with CalVoices. We are a sponsor of AB 96. The good news is the bill is not dead. It's a 2-year bill, and we really appreciate Dr. Jackson for his tremendous leadership. We just want to bring to your attention that we have accepted the amendment to reduce the focus of the scope of practice for peer services. We strongly believe that aligns with the CALIM initiatives. We believe it addresses the labor shortage California faces currently. I think it's consistent with the overall CALIMs and ECM growth. We just want to bring to your attention that California has invested millions in establishing the peer certification program and supporting the peer placement and training program to train and place MPSS. California can use this trained and certified MPSS as part of the CHW workforce to serve thousands of ECM members with behavioral health needs. Without that, there's only 8,730 CHW workers in California, and that number is inflated because the U.S. Bureau of Labor Statistics also include PSS as part of the number. So California will not be able to meet its need to train 25,000 by 2025 unless we integrated the CHW and PSS. This is good, fiscally sound, and policy as well as the policy. Thank you for your time.
Thank you. Our next comment is online, and it is from Rakaya. Your line is open.
Hi everyone, Rukaya Ahmed. I use she, her pronouns from the California Pan Ethnic Health Network, or CPEN. I just wanted to say CPEN is, really proud to work closely with peer support specialists and community health workers, promotoras, and representatives across the state. And we really believe both workforces play a very critical role in healthcare, and they bring distinct expertise, they bring training pathways and histories. And now, we understand that the bill is now a 2-year bill, and so we really look forward to conversations to really ensure that the bill uplifts both workforces and centers equity. And, if there are other concerns that were raised, please do reach out to us and we'd be happy to discuss. Thank you.
Thank you, Rakaya. Our next comment is from Jay. Your line is open.
Good afternoon, Madam Chair and Commissioners. Jay from the California Behavioral Health Association. We are one of the co-sponsors of AB 348, which you are considering for support. We just wanted to urge your support. FSPs are a proven solution to reducing reliance on behavioral health service delivery, and it reduces reliance on those systems, on upstream positions while promoting community safety. There was a study between 2021 and 2022 that saw a 41% reduction in psychiatric hospital admissions in the state after clients joined full service partnerships. But despite support for those interventions, there's a lot of eligibility and enrollment variation between counties, which creates an inconsistent and inequitable service delivery system. And it's causes overly complicated and fragmented criteria, which blocks some of the individuals who need those services the most. So to ensure that California's most vulnerable populations are prioritized under full service partnerships, especially as they are expanded under Proposition 1, AB 348 will establish presumptive eligibility for individuals with severe mental illness without forcing counties to go over their capacity for full service partnerships. So by creating that presumptive eligibility requirement for Proposition 1, California can guarantee that valuable resources are directed to services and individuals with the most need. Thank you, and I will pass it along.
Thank you. Our next comment is from Selena. Your line is open.
Thank you so much. This is Selena Lou Raphael from the California Alliance of Child and Family Services. We want to just thank you so much for highlighting these important bills. And we are co-sponsors of SB 531. And we just truly believe that children understanding how anxiety and depression feels before it gets to a crisis, where it's about suicide prevention, prevention of bullying, school shootings, other things, we believe that as children start to understand how they feel before it becomes a crisis, it could really impact the whole state. So thank you so much.
Hey, Eric.
Hey, Mike, do you want to talk for just a couple minutes now?
Thank you. Our next comment is from Laurel. Your line is open.
Hello again. I want to talk about SB 823, which wasn't brought up. It's an expansion of CARE Act, and CARE Act was not in Proposition 1 explicitly, so to speak, but it's certainly part of the governor's overall strategy. And this is the year of the all-county rollouts. Well, there's been a suggestion in SB 823 that bipolar 1 be added as a condition subject and accepted, could be accepted to be handled by a care court. That has negatives and positives, positives and negatives. I would like to hear that this presented to the commission and thought about by commission members as part of your work. And also later in this year, I think it would be useful to have a report on how the care court rollout has gone. Thank you.
Thank you. That was our last public comment.
I'm going to go back to our motions. We have two motions. Was there any additional commissioner comments? Okay.
Actually, there's several motions. I don't know if there's 4 or 5. I want to get the exact count from Kendra, but we have them prepared here.
Yeah, they're on the slide. 1, 2, 3, 4, 5, 6, except AB 96 is direct staff to participate in conversations. I don't know if that needs a motion. That would
No,
be
that
the
does not need a motion.
Okay, so then 5.
And do we have to vote on each of these individually?
You
or can we vote-
Yeah.
Okay. Okay. Hearing that.
Wait, I'm sorry. Can you explain the AB 96 again? So we're not supporting it at all right now? You're just gonna.
You can choose to support it, but I don't.
It's a 2-year bill, which means it stops now and picks back up in January. So there'll be ongoing conversations until then and next year. And so, I mean, you can support now, but it could change. You know, it's kind of like we should participate in those conversations and be a part of that conversation moving forward.
Okay. So we'll take these one at a time.
I'm sorry.
Another question?
I have another question. It says direct staff to communicate its position to the legislature and the governor. Does that assume that we know what the position is that we're taking?
It says support on all of them.
Okay, so
yeah.
I don't know, I mean, if everyone, I don't know that everyone agrees to support it, in which case maybe it does need to be a vote. Because I'm not sure that I would necessarily vote to have you guys join in a conversation where we're supporting something if we haven't actually voted
Oh,
to support.
sorry. No, just participating. For AB 96, it's not a position, just participating, bringing back the information, and then you could vote as I bring back and update the commission. So not a position, just participating in the
So
process.
can we update the motion? Because the motion says direct staff to communicate its position.
Yeah.
But we don't actually have a position.
Yes, yes.
Okay, so can I just get that, we're doing AB, I'm trying to track.
This is AB 96, but Sandra, you also said maybe we don't even need a motion to do that if you want staff to participate. That's your call.
If I could just clarify, maybe to cut through, the slide was prepared before the committee took amendments on Tuesday. So this was an old recommendation. Yeah, I mean, we don't have to talk about it anymore.
Okay, so I will cross it out.
We have to do them individually, and we're at SB 3.
Got it. So we'll start with SB 320, correct? Okay,
Yes,
so
SB
we'll
320.
run the question, and then I'll need a motion and a second for each one of these motions.
Do we have a motion and a second for, from commissioners on SB 320?
So moved. Can I move?
Yeah.
Yes. Second. We have a motion and a second. All those in favor of staff recommendation around SB 320?
Okay, I will run the roll call. Commissioner, and please, online commissioners, please unmute your lines. We're going to be taking about 6 consecutive votes, so I'm really hoping that we can just move those quickly. So if you have your line unmuted, that'll help speed things along. Commissioner,
And can you show the screen while we're voting? Is that
Yes.
possible? Thank you.
so this is, the motion is for SB 320, introduced by Chair Alvarez, seconded by Commissioner Bunch. Going in favor or not? So Commissioner Bear,
Aye.
Commissioner Burnick,
Aye.
Commissioner Bontrager,
Aye.
Commissioner Brown, Commissioner Bunch,
Aye.
Commissioner Callan,
Aye.
Commissioner Carnevale,
Aye.
Commissioner Chamber,
Aye.
Commissioner Contreras,
Aye.
Commissioner Designee Swartz, Commissioner Cross,
Aye.
Commissioner Fairweather,
Aye.
Commissioner Fernandez,
Aye.
Commissioner Gordon,
Aye.
Commissioner Designee Pulmano, Commissioner Larson, Commissioner Madrigal Weiss,
Aye.
Commissioner Mitchell, Commissioner Robinson, Commissioner Southard,
Aye.
Commissioner Sy,
Aye.
Commissioner Wilks, Commissioner, Chair Roulette, Vice Chair Roulette,
Aye.
Chair Alvarez.
Aye.
Motion passes.
Next, we'll take on AB 348 as we are skipping AB 96. Do I have a motion to accept staff
Do
reference?
we have a motion? Who is that?
Right. Second?
Who, do you have a second?
Second.
Okay, Contreras, thank you. We have a motion and a second. Commissioner Bear,
Aye.
Commissioner Burnick,
Aye.
Commissioner Bontrager,
Aye.
Commissioner Brown, Commissioner Bunch,
Aye.
Commissioner Callan,
Aye.
Commissioner Carnevale,
Aye.
Commissioner Chambers, Commissioner Contreras,
Aye.
Commissioner Designee Swartz, Commissioner Cross,
Aye.
Commissioner Fairweather,
Aye.
Commissioner Fernandez,
Aye.
Commissioner Gordon,
Aye.
Commissioner Designee Pulmano, Commissioner Larson, Commissioner Madrigal Weiss,
Aye.
Commissioner Mitchell, Commissioner Robinson, Commissioner Southard,
Aye.
Commissioner Sy,
Aye.
Commissioner Wilks,
Abstain.
Vice Chair Roulette,
Aye.
Chair Alvarez.
Aye.
Motion passes.
Next, we have a motion, can we have a motion regarding AB 1037?
I'd like to make the motion.
All right. Second?
I'll second.
Thank you.
We have a motion and a second for AB 1038. Commissioner Bear,
37?
37, I'm sorry, you're correct. Commissioner Bear,
Aye.
Commissioner Burnick,
Aye.
Commissioner Bontrager,
Aye.
Commissioner Brown, Commissioner Bunch,
Aye.
Commissioner Callan,
Aye.
Commissioner Carnevale,
Aye.
Commissioner Chambers, Commissioner Contreras,
Aye.
Commissioner Designee Swartz, Commissioner Cross,
Aye.
Commissioner Fairweather,
Aye.
Commissioner Fernandez,
Aye.
Commissioner Gordon,
Aye.
Commissioner Designee Polmano, Commissioner Larson, Commissioner Madrigal Weiss,
Aye.
Commissioner Mitchell, Commissioner Robinson, Commissioner Southard,
Aye.
Commissioner Sy,
Aye.
Commissioner Wilks,
Abstain.
Vice Chair Roulette,
Aye.
Chair Alvarez.
Aye.
Motion passes.
Next is SB 531, Rubio. We have a motion
I'd like to make the motion.
and a second.
Aye.
All right.
Second, Ralph.
Thank you, sir.
We have a motion and a second. Commissioner Bear,
Aye.
Commissioner Bernick,
Aye.
Commissioner Bontrager,
Aye.
Commissioner Brown, Commissioner Bunch,
Aye.
Commissioner Callan,
Aye.
Commissioner Carnevale,
Aye.
Commissioner Chambers, Commissioner Contreras,
Aye.
Commissioner Designee Swartz, Commissioner Cross,
Aye.
Commissioner Fairweather,
Aye.
Commissioner Fernandez,
Aye.
Commissioner Gordon,
Aye.
Commissioner Designee Polmano, Commissioner Larson, Commissioner Madrigal Weiss,
Aye.
Commissioner Mitchell, Commissioner Robinson, Commissioner Southard,
Aye.
Commissioner Sy,
Aye.
Commissioner Wilks,
Abstain.
Vice Chair Roulette,
Aye.
Chair Alvarez.
Aye.
Motion passes.
Last, SB 862, Senate Committee on Health. We have a motion? I'll second. Oh, I don't know if the chair can say.
Second.
Callan,
Callan,
second.
second.
Perfect. For SB 862,
Yes.
Commissioner Bear,
Aye.
Commissioner Bernick,
Aye.
Commissioner Bontrager,
Aye.
Commissioner Brown, Commissioner Bunch,
Aye.
Commissioner Callan,
Aye.
Commissioner Carnevale,
Aye.
Commissioner Chambers, Commissioner Contreras,
Aye.
Commissioner Designee Swartz, Commissioner Cross,
Aye.
Commissioner Fairweather,
Aye.
Commissioner Fernandez,
Aye.
Commissioner Gordon,
Abstain.
Commissioner Designee Polmano, Commissioner Larson, Commissioner Madrigal Weiss,
Aye.
Commissioner Mitchell, Commissioner Robinson, Commissioner Southard,
Aye.
Commissioner Sy,
Aye.
Commissioner Wilks,
Abstain.
Vice Chair Roulette,
Aye.
Chair Alvarez.
Aye.
Motion passes.
Fantastic. Thank you so much, everybody, and thank you, Kendra, for that extensive report. Looking forward to continued movement in the legislative arena. The next agenda item is an update on our recent allocations. One of the commitments that this commission has made is to renew transparency with the public as well as our commission and team in its entirety. We want to make sure that you are informed about how grants and contracts are being executed. So I'm going to ask our interim director to share any updates on the funding decisions made by the commission at our March meeting. And then I will share some comments after his remarks.
Thank you, Chair. At your March 26th meeting, you approved commission funding for 3 distinct items. This afternoon, I'd like to update you on how we've been moving forward on those commitments, and I recommend it to be a practice so that we are all reinforcing that our goal is not just to sort of get agreement signed and get money out the door, but that it's really to be purposeful in what the commission was seeking. You approved $4 million in Behavioral Health Student Services Act funds for West Ed to undertake the second phase of the evaluation of the initiative. We have met with West Ed principals on the project and were able to reinforce the Commission's expectation that this is not to be just a retrospective accounting of everything that took place over the past 8 years, but rather something that focuses on situations in which the grants produced the most meaningful changes in how school districts and county behavioral health develop partnerships, and how those, in those instances, really sort of illuminate how staff-to-staff relations were improved, how they helped increase access to mental health, and increase the use where they did of third-party payments and the culture changes that supported those changes. I'm satisfied that our team and the West Ed team are of one mind on this, and we emphasize that we will be expecting real-time, regular updates on their findings that may be useful in building out the larger future efforts to center behavioral health care for young people in the schools and colleges. And so I feel that we're moving in the right direction. You approved $3 million in Mental Health Wellness Act funds to redistribute among the empath crisis unit projects. $1 million to bring Sutter Coast Hospital up to a consistent funding level with the other 9 sites, and then the remainder to be available to the other sites. We've been engaged in a 2-step process on this. First, we wanted to satisfy ourselves that the delays we have seen in project startup were not the result of fatal inconsistencies between the model and California licensure and regulations. The outcome of that investigation was reassuring that the current programs that we're supporting do have pathways forward to begin operation, although they're slower than expected under the current regulatory environment. We will continue to work with HCI and Department of Public Health for regulatory changes that will create an easier path in the future for future projects, but these can move. So we've now asked the hospitals to identify unmet needs and any unexpected costs in their projects, and we'll be working with them to ensure that we are prioritizing distribution of funds to must-have rather than nice-to-haves, because I'm sure that's really the intent. So that is the update on, one other. You did you approved funding of almost $1 million in Mental Health Wellness Act funds to supplement the Older Adults Behavioral Health Initiative. And so staff has begun the process of determining which of those projects that we're engaged with sort of have, for lack of a better word, shovel-ready opportunities that if we put resources towards them, they can take advantage of situations that are available and that meet needs in the communities they're directed at. So I anticipate that all of these will be negotiated and executed by June. So that's the update.
Thank you so much, Will. Appreciate that. I also want to reiterate in our commitment to establishing trust and being more transparent in our practices, we've explored what more the commission can do to demonstrate that commitment. So one of the items that I've requested of the commission is to produce a quarterly report of every contract and grant that's been signed. So that will be publicly available on our website, and hopefully will happen starting Q2 of this year. Again, this is public resources that are being distributed and that should be made aware to the public of how they're being utilized. And again, just offers additional insights into the operations of the commission. So huge thanks to Will and the team, Norma and others for their work and commitment to making that happen. With that, I would like to open it up to commissioners to offer comments or ask questions. Seeing none, Mariani, if we could go ahead. Oh, just kidding. Please, Commissioner Wilkes.
So just some questions, don't need any response. Just wanted to know how the insurance industry is impacting the work that we do. And then also if there was any stories or impact from the LA fires on our work too for a future meeting.
Yes, Commissioner. Let me just mention at our last meeting, we actually had a presentation from both commissioners and virtually online from sort of representatives of sort of related entities talking about the known impacts at that point of the fires, as well as sort of alerting us to let's, these are going to be the downstream issues that are going to emerge somewhere, so that the commission can sort of be thinking about this in your future planning for things you will want to undertake. As you know, the Mental Health Wellness Act, which the commission has, and we referred to this morning, is an ongoing fund that the commission has access to of $20 million a year. And the commission has sort of set priorities in the past that say, we're interested in this, this, and this, and this, and we'll spend 3 years doing it. As those 3-year projects roll off, the commission should be thinking about, what needs to happen out there that we can make a positive impact on. And so certainly I think one of the areas you'd want to stay alert to is have we now learned something about impacts, lasting impacts in the LA situation around behavioral health that we should be trying to, address.
I'm just wondering, in that same vein, have we started, and I wasn't here last month, but started a discussion around how we can support and help our immigrant communities right now, and what we're going to be doing going forward to support?
As a commission, we have not had a sort of a strategy session on it. One of the things that hopefully we can do now that we're sort of executing the new set of contracts with that we approved this morning on the immigrant refugee providers is now work with them to talk about what would you like to see the role that the commission could play in this. What's the strategic opportunity, and sometimes the strategic opportunity is to sort of take moral stances, and that's legitimate, and maybe they would like to see some action from us in those areas, but maybe there are specific interventions that can sort of help support the communities.
Is that something that could be a committee that we start, or should it be a committee, or is there a way for commissioners who are interested to get involved?
Madam Chair, if I could just make a recommendation, because all the new commissioners coming on, there's that and a lot of other new issues, and maybe in the context of our strategic plan, we should actually do a kind of a refresh or an examination of, and bring in all of those new opportunities and then compare them as we think about and with the new executive director.
Thank you so much. That's a great idea. I do think that it's important to consider it within the program committee and the resources that we do have, but also with these new contracts that will be awarded, that's a direct line to the community to say, here's what we're hearing, here's what's getting elevated, here are the needs as they have identified them that could come to the commission and present to us. Like, that's the point of these advocacy spotlights. So I completely agree, Commissioner Bunch, that that's very necessary, and want to explore the avenues of communication that we have here at the commission to demonstrate that. During Trump 1.0, we didn't have those awards. So we actually did a site visit. We went to San Diego. We had a panel presentation. There was a lot of work associated with that. How do we build on what is happening now in order to meet this moment? So appreciate those comments. Please.
So as vice chair of the program committee, I think to identify a place where this sits would be important. And so I appreciate that. So I think, trending issues, and this is something that's come up, and it continues to come up, and there's a very aggressive movement towards these communities, and I think we need to be responsive, because 1.0 was bad, 2.0 is accelerated, and I think we need to be preparing and really providing guidance to our communities, and more importantly, hearing from our communities so that we can then build in guidance to get back out there. So appreciate what you brought up, Commissioner Bunch, and would love to sit down, and if it is with programming, then as Commissioner Sy is going to be taking the lead, I think it'd be important to absolutely bring that up. So thank you.
Thank you. I also think to the extent that commissioners are aware of opportunities, educational opportunities at this moment, because there is a lot happening across the states in response to these issues, both with LGBTQ communities, immigrant communities, just everyone that's impacted. If we can share those with staff, that can then be shared with the commission. I think information sharing is critically important in this moment. So I encourage commissioners to please put forward those opportunities for learning to the whole commission. Any other comments or reactions? Yes.
I assume we were putting off item 12. I was hoping to try to do it very quickly. Right. 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 Yeah. Let's talk process on this because our timing is awkward right now. There are three things in.
Excuse me, can you repeat the question because we could not hear online?
I'm sorry. The question is about item 12, Innovation Partnership Fund update.
No.
And I was asking about what is the process, given that we don't have more than 5 minutes now, to try to winnow down these suggestions to things that the commission would propose actually starting work on, and what's the process intended to be?
We've got three things in your package that and that are sort of available on the website that we would refer you to. The goal is not today to do the winnowing. Our expectation is that we should start planning a process for the winnowing for the May meeting and really focus a large part of that meeting around a structured process for establishing goals. Are we talking the BHSA population or the broad population? Are we agreed on what system change looks like? Of the concepts that have been surfaced, which ones look like system change or have the potential for it versus which ones look like good, innovative projects, but something we would either take up under the Mental Health Wellness Act or some other setting, and then narrow it to a short list of what we think have great potential. And then the recommendation that staff is bringing is that you would then refer that shorter of the shorter lists to the program committee and ask them to sort of, because we don't have a June meeting after the May meeting, so ask them to sort of take the dead period to do a sort of a pros cons analysis on the concepts that have been suggested, either those that are sort of listed here, those that we've heard before, anything that may come in between here and May. And in that pros cons, be looking at both, is it moving our goals in an obvious place? How feasible is it? Are there risks involved in it? If so, what are the risk mitigations? To the extent that we're focused on partnerships, what is the bankable assurances that different partners are bringing to the table? And then with the expectation that the program committee would also potentially be doing the required consultation with the Health and Human Services Agency, the Department of Healthcare Services, HCI, and CDPH during that period, so that what's coming back in either the July or the August meeting, depending on how far they've been able to get, is really a sort of a specific set of recommendations. We suggest you take on the following 2, 3, 4, whatevers as part of the Innovation Partnership Fund, and then that's decision point for the commission. The commission either says yes or doesn't agree on it. But once the decision is made, then we start moving it to the staff process of implementation with the realization that the commitment we have is to have stuff ready to go July 1, 2026. What we did, now just to sort of changing the flow, but bear with me. As you know, back in the February meeting, we sort of did a conceptual update on what the Innovation Partnership Fund is, what it was created for. And at that point, we had a presentation that Commissioner Carnival gave the lead on some thinking that he and others had been considering. We thanked him for it, and we also said, but we need to hear from, what are the other interests that we will have. We distributed a call for concepts basically to our stakeholder constituencies, and asked, sort of with the goal of getting it in by mid-April. That's a very flexible date. It's still coming in. So even after this was printed, there have been suggestions. And what I was seeking to do with this is to not go into the details of the concepts themselves, but to illustrate the areas in which our constituencies are hoping we can have big impact. The summaries done in this document don't do justice at all to what people had sent in. This is sort of just glimpses. And what I would anticipate is going to happen is between now and that May meeting, staff will be working on all of the concepts that were submitted to sort of present more substance that does justice to the organizations that took the time to send their ideas in, and then sort of, as I'm suggesting for May, sort of have a facilitated commission conversation about how do we make sense of this? What are the real opportunities here? I think we have a slide deck that can be put up.
I just want to make sure that, have we moved on to agenda item 6? Because no.
We're on 12.
Oh, 12. Sorry about that.
No worries.
I just want to make sure that we're tracking.
So is there a slide deck for 12?
Sorry. No, that's what I'm saying. We didn't close out public comment on agenda item 6.
Public comment on both at the same time?
Technically, they're supposed to each have their own public comment.
Item 6 was the update on
Yes,
the
because we
funding
haven't closed
allocation.
off 6 before we can, move on. But yes, we can combine. We're at time, so we're already.
Right. Let's
Okay.
combine comments
Okay.
after, because there may be on both. So if I could, I don't have the clicker, so I'm going to be asking folk verbally to make the moves. Then if we go to the next, no, back one. Oh, no, okay, that's fine. Yes, CDEPs were, most of the responses that came in reference CDEPs and the importance of sort of finding ways of making CDEPs part of the regularized system of service that can be reimbursed in the behavioral health delivery system. And there was also sort of emphasis on particular populations may have developed or may be looking at particular community-defined evidence practices. And so it's important to be focused. And then the whole question of how do counties integrate CDEPs into their service array. If we could go to the next slide. Workforce was the other big sort of response that we were hearing from. Can you advance? Oh, thank you. Among the sort of ideas that were coming in was, HCI was sort of suggesting to us, could we pilot some community-based health education training programs that integrated mental health and SUD care at the non-licensed level, but the sort of training that can be provided in community college settings or state university settings, producing a certification process that could then sort of leverage the scholarship opportunities in the BH Connect, the almost $2 billion in BH Connect. So that's just a suggestion. Agency was basically saying, support inclusion of SUD in everything BHSA. Figure out the ways to make it work. It's not integrated at this point. and it's not going to happen by accident. So there's sort of basically a suggestion that we take leadership in pointing how that workforce development integration happens. Again, further development of peer support, and then a suggestion that we look at how AI tools could be developed and used to lighten the administrative burden on the front-end staff. I mean, one of the things that we see in a lot of the workforce surveys is that the workforce doing the work are burning out because of requirements for absolutely, what they would call unrelated charting, billing type things. Is this a place that AI can, fundamentally relieve that stress? That's certainly something which a variety of people have raised. And then some specific recommendations are coming in around particular high-need populations. Let's go on to the next one. Community engagement. Agency was sort of recommending that we increase community participation in building out the SUD component in behavioral health services. And then private organization, third sector was recommending behavioral health community councils, more or less for the same purposes. And then there was a significant sort of focus on perhaps Stacy's comment about legislation, the need to sort of advance the accessibility and knowledge and acceptability of various behavioral health services in the Asian American Pacific Islander communities. So let's go to the next one. SUD disorders. A strong call from agency in particular that the commission take leadership in fully integrating SUD services, not just into the workforce dimension, which they referenced before, but into what design systems have to change for SUD to be well integrated into full service partnerships, that behavioral health supports and services, programs within BHSA schools, housing and prevention. I mean, it's how do it. There's a specific concept that UC Davis health systems want to engage us around to how do we move medically assisted treatment out of the hospital setting so that when the person who is leaving hospital or leaving jail or prison or wherever they may have been getting MAT services doesn't just fall off the cliff and wind up returning to unhealthy activities because they weren't able to get ready access to services. Let's go to the next one. The California Alliance had a suggestion around trying to develop a cross-county hub model across the state to simplify access and coordination for behavioral health services for youth and foster care, regardless of geography or payer source. So currently, frankly, the care and services that are available to youth are quite geographically dependent, and youth in care in one setting versus another county may have very different resources available to them. And so a suggestion, PPP, online programs and then school-based health centers is also something that people are saying, can we use the innovation partnership to move this forward? The next one is technology, again, using AI tools to relieve administrative burdens, and then a proposal for, or not a proposal, but a concept around sort of an automated tool that would enhance early response to mental health issues emerging through real-time passive symptoms approaches. Again, I'm not nearly close enough to the field to know what that is. It sounded good. And then the long list in just the system improvement and strengthening. Agency, interestingly, is the one that suggested sort of that the commission sort of take a look at what would be a strategic plan to reduce disparities in behavioral health. What would it take? We have the data warehousing capacity to sort of track stuff. So if we were to try to develop 5-year goals and 10-year goals and sort of to work to a plan, that would, from their perspective, be a big system change opportunity. Our partners at Healthy Brains Global Initiative were suggesting outcome-based payment strategies for contractors supporting people coming out of jails and prisons. Others, you can read these sort of approaches on the list. So all of these have come in. Whether they fit in the system change bucket or they're nice ideas is something which I think is the next step in our process to sort of engage on, to give them their good and just hearing, but also recognize that not everything does lead to systemic change, even if successfully done. So we have to be clear and clean about what that distinction is. And then once we're clear on that, some things may go to a parking lot sort of place where, yeah, we'll get back to that if and when we have free resources. But these are now the other things we want to seriously start moving forward. So, Commissioner Gordon, to your point, yeah, not in any way a suggestion that we would embrace all of these, but definitely want to make the public recognition that these have come in from our public as the things they want to see stuff happen around. And whether that's innovation partnership, jurisdiction, or Mental Health Wellness Act, or other stuff. In this year, we have not, for a variety of reasons, been sort of as active as sometimes historically the case in going around the legislature and shopping ideas and saying, gosh, wouldn't it be great if somebody put up some money to do this or do that, do that. I mean, this also could be one of the things that could start generating that sort of interest or list, so that it may fall outside of the normal resource routes that the Commission has access to, but that we can encourage other people to pay attention to. So that's where we are. Yeah.
Can you put your mic on, please, Commissioner Gordon? Thank you.
Next meeting in June would then
May.
be our chance to comment on these potential initiatives and make suggestions around them.
Yes.
For the program committee then.
Exactly. You took the words right out.
And the other thing I would encourage for that May meeting discussion is I don't think we should treat this as a closed door yet. And if there are commissioners who are thinking of things that they'd like to surface for consideration, please, work with us at the office to say, I'd really like to bring this forward. Let's figure out a way to present it.
That was going to be my question, is the process still open to the public? No?
Yes.
Oh, it is?
I mean, from my point of view, until the May meeting, we'll try to find ways to bring concepts in. But it's certainly, until the May meeting, I think we want to consider it still open.
Okay. And then you want commissioners to not use that to reach out to staff?
I'm sorry, I didn't.
Oh, how do we get our ideas as commissioners to, yeah.
My suggestion, frankly, would be send me an email.
Okay.
And I'll sort of direct it to the folk who can productively do that. But because I mean that's the moment where things, and partly I was hoping that sort of just seeing a list like this might provoke some thoughts of saying, we should think, something we should think about is, and all right, So I'm done.
Thank you. I recognize we are over time, but I do want to highlight that at that May meeting, there is an opportunity to build on these ideas, bring forward new ones, but also to discuss the Venn diagram of sorts of many of these proposals. Like you broke them up into categories, but if you really look at them, many of them are overlapping in the application of what sort of buckets they are falling in. And I think that's an important message to convey to the public about what we're looking for. The other piece that's really important is innovation and what does that actually mean, right? And is there any specific criteria or viability of these projects that we want to consider in moving forward? And so we're also exploring, there are other entities that have done these sort of public-private partnerships that the commission can learn from. Commissioner Carnevale has highlighted some, county offices have some. So how do we uplift those best practices? This is new territory for the commission, and we want to learn from others on what they've done as we embark on this new opportunity for us to make impact. So that will also be part of the May conversation that will then inform the program committee's work moving forward. Any other comments? Okay, I'm going to hand it over to Amariani for public comment on both agenda item 6 and agenda item 12.
Thank you. We currently have one in-room comment. If you could please just let us know which item you're commenting on. Thank you. Our first comment is Stacy.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. This is on item 12, the Innovation Partnership Fund. Yes, this is a gigantic project to try to narrow down, and I admire and thank the Commission so far for their efforts. I just hope that the community is included in winnowing down and in at least your discussion. The only thing that concerned me at all was in this write-up here where it says at the May 2025 meeting, you should have a facilitated commission discussion to determine whether the Innovation Partnership Fund should be focused on BHSA priority populations, the wider behavioral health ecosystem, or different initiatives with different targets. Some of that I support, but I really want the commissioners, and I'm going to send this to you guys. The language from the statutes under Proposition 1 regarding the Innovation Partnership Fund says it should be used to improve Behavioral Health Services Act programs and practices funded for the following groups. 1, underserved populations. 2, low-income populations. 3, communities impacted by other behavioral health disparities. And 4, other populations as determined by the Behavioral Health Oversight and Accountability Commission. And if that's what you're talking about, number 4, I just want you to remember you cannot leave out those first 3 populations. And I will have the community out in mass if those get not prioritized, because it says so right in the act. And again, thank you. This is going to be a big undertaking, and we're here to help. So let us know how. And again, people are waiting for me to tell them when you guys are going to have open public meetings so they can listen and comment. Thank you.
Thank you, Stacy. Our next public comment is from Kevin. Kevin will need extended time for his translator as well, his interpreter. Please let us know when you are ready to go ahead and speak for Kevin. Andrew, could you let Kevin know that
We can't hear
We
you.
don't have an interpreter for him actually speaking. Okay. We will.
Yes, hi. Sorry, we're gonna need we a technical issue. We're trying to get Kevin's attention and let him know. And Elliot's having a hard time unmuting himself.
Okay.
It's not letting him unmute him.
Okay,
It's not letting him unmute.
We'll circle back while you guys figure out those technical difficulties. Next, we have Wendy. Your line is open.
Hi. Hi, my name is Wendy. I'm calling from Orange County, and I'm with the Mental Health Association for Chinese Communities. And I appreciate all the commissioners mentioning of the immigrant underserved population in which my population represent and is a large percentage of. Um, and I just want to ask, you guys mentioned the immigration, refugee, and advocacy grant that along with the two other ones. I'm wondering, how do we find out where the awardees are? Because I'm looking at the materials and the agenda as well as the handouts, and I don't see it posted on the website, on the committee meeting website.
Thank you, Wendy. We had to, we had to publicly announce that at our meeting. Now, per our rules, we have to allow a protest period, and then we will publicly post the names of the awardees to our website.
Oh, okay, thank you. Do you know when that would be?
Just kidding. They are posted, Wendy, but there is a protest period. So it's not a final list of organizations until that protest period is complete, but they are on our website.
Okay, like when would the 5 working days? Okay, I just saw it. It just updated just now. Thank you.
Thank you.
Thank you. We'll circle back to Kevin now. Elliot, I'd like to confirm that you're able to unmute yourself.
Can you hear me now?
Yes, we can hear you. Thank you. All right, Kevin, if you would like to go ahead.
All right, thank you so much for this opportunity. And it's really exciting to hear about the funding and the support for deaf and disabled people. And I'm here in Southern California, but also speaking for Northern California, I encourage the community, more outreach to the community for these innovation grants. And I would ask the commission to consider funding intervals for an addition for disabled committees. And I would need an interpreter to work with my community. So we would need interpreters. It's not always on my shoulders to find the interpreter. So I would like to see that added into the budget, like a line item that will supplement the funding and for more organizations to become part of that. The second thing I would encourage the commission, I would like to be involved more in advocacy, and I don't see any deaf or disabled on the committee. I don't see anybody representing the special needs of that population. So I'm wondering, I feel often we are excluded from this. And, that's a big question that I have. And also as far as budgeting, you're talking about how to allocate budgeting, but we're not represented there. So we need something from the commission for us as well.
Thank you, Kevin. Our next public comment is from Richard. Your line is open.
Hello, Commissioners. I want to make a comment to the interim executive director regarding the impact funding. I made an inquiry with my particular hospital in Santa Cruz, Dominican Hospital, which is called Dignity Health. And I was not pleased with their response. I did not have a good feeling whether the funding is being adequately used and whether the SMI community is actually being served through their ER doors. So I want the commission to be aware of that. I never went back and followed through because I just got caught up with other projects and working and et cetera. So the commission needs to be aware of that. I find it very questionable whether that particular hospital is utilizing our tax dollars well. Secondly, as regards to the workforce, we do have enough individuals with lived experience as peer workers, whether it's mental health, substance abuse, alcohol, being unhoused, domestic violence. It just goes on and on. That can serve the substance abuse providers with our workforce. It's just a matter of FHP being creative in how they want to establish their program. Are staff going to be generalists, doing everything what needs to be done? Or is staff going to need to specialize a particular area? Affordable housing, benefits counseling, peer support, support group, domestic violence support group, personal attendance services and self-advocacy. And it just goes on and on. If you will look at the way Centers for Independent Living is operated throughout the United States, there are over 300 of them. And we have every county in California operated by for the disability community, including the deaf community. That model can be followed within the full service partnership model as well. I remember making this suggestion maybe over 2 years ago. I'm guessing, but I don't know whether commission followed through when Stephanie Welch gave her part of this presentation before or after Proposition 1 passed. I can't remember, but I did make it clear to the commission to look at this as a way to have a well-established program. Secondly, to see and monitor goals that are being reached by the SMI community of what they're trying to achieve to regain their independence, to be reintegrated into the community as part of their independence, or getting their independence back, whether it's released from jail. So look at that model. It can work within the SFP. Thank you.
Thank you, Richard. Staff has also asked if you could send an email with your comment. That way we can follow up with you directly. We want to make sure we didn't miss any of the details from your comment. Thank you. Our last public comment is from Laurel.
Okay, good afternoon again. I'll make this fast. I totally back up what Stacy Hiramoto said about the innovation partnership. So I won't go over that. 3 things from the previous presentation about the California fires in Southern California. Question I think the commissioners would want to know, is FEMA funding mental health help through CalMesa with CalHope, which it did during COVID? And some of those were mental health services provided by peers in many languages. Or is that funding been cut off from Washington? After the Paradise fires and the Napa-Sonoma area fires, also there was help from FEMA, sometimes directly to the counties. And we need to know, is that been cut off? Or is that now a problem that the commission might want to be concerned about and at least informed about? Second, I understand that with the executive order from Washington, that English is now the official language of the United States. Language access through interpreting services and translating services is now voluntary, no longer obligatory from the federal viewpoint. Do our California laws ensure that organizations, entities, corporations, and systems will not follow the voluntary model, but will consider that they must provide these services? That's something we need to know. And last, something that I just learned this week, now Medicare patients can no longer have telehealth visits. That's a serious change. There may be good reasons for it, but it certainly is going to have an impact on people who are unable to drive to services. And something we learned during COVID was that telehealth mental health services work. Before, it was the clinicians who did not want to try that. All right, it's good to be conservative in innovation, maybe, but the hand was forced, and they actually found out it worked really well for the patients and even for their own. So thank you, and backing up Stacy again.
Thank you, Laurel. That was our last public comment.
Thank you, Mariani. And thank you, everyone, for the public comment. While I know it is not custom to respond to public comment, I just want to make clear that executive orders are not laws. Executive orders are then interpreted. English is not the official language of the United States. I think it's worth clarifying that. And I think it does highlight the opportunity to ensure that this commission is educating our public where there are policies or confusion that we hear from our stakeholders, where there may be opportunity to band together and share some educational opportunities around changes to Medicaid or changes to Medicare and things that might have implication for the behavioral health delivery system. Again, there are a number of resources within this commission itself, but within our broader community that can be brought to our broader public stakeholder community that I think would be helpful in these very challenging times. With that, I would like to thank all of our commissioners for joining us today, as well as the members of our public and staff. A big welcome to our new commissioners. Thank you for being here. We look forward to seeing you next month. I adjourn the meeting at 3:31.